Hello, everyone. A very warm welcome to you all to the remarkable rapid revision. So, so in this session, this is going to be a very high yield topic in which I would be discussing the very important topics from obstetrics and gynecology, and I would be covering nearly all the previous year questions that has come as well. So this is going to be very high yield content. So I'm Dr. Gayathri, your Obs and Gyn faculty. So before starting, I would like to thank Dr. Tutorials as well as ISM, Dr. Bhanuprasad sir, for giving me this opportunity, which allows me to share my knowledge with you all. I'm very thankful for this opportunity. So let's start this remarkable rapid revision. Hello, Moonchild. Hello, Kishan, Rahul. Good evening, DSW. Hello. Hello, Avinash. So welcome to the session. Yes. All right. So without further ado, let's start the session. Yes. Hello, Footprint, Hussein, Medico, Shivani Roy, Bobby. A very good evening to you all. Woodcutter Rawat. Very good evening. Yes. Saddam. Thank you, DSW. Vaishnav, Satya, Ritesh. Yes, good. Yes, this will be useful for NEET PG as well because, as you know, most of the high yield topics are nearly same. The exact questions might differ, but there are a lot of topics which get repeated again and again for all these exams. Yes, definitely this is going to be useful for NEET PG as well. All right. So let's start one by one. So this is basically my Insta link as well. So I have shared a lot of previous year questions and high yield points there also. So you can connect with me through it. And at the end of the session as well, if you have any doubts, any personal questions about the obstetrics and gynecology, so you can definitely ask me and connect to me as well. Yes, Woodcutter, regarding the PDF, definitely it will be provided. Do not worry. So sit back and you can learn from the class. Yes. Yes, definitely. Most of the previous year questions have been included as well. So for the both exams, it's going to be yes. So let's start. First, let's start with the image-based question, which has come up as well. Antepartum hemorrhage is an extremely important topic. So first, have a look at these images and try to identify the abnormalities in the placenta as well as in the cord, which is given here. So the first one, as you see, it's a normal placenta. You can see the fetus, then normally located placenta as well. In the second image, you will see that there is collection of blood behind the placenta. You can appreciate there is collection of blood behind the placenta. So premature separation of a normally located placenta. This is basically an example of abruption. Again, this has come previously as well. So such an image is abruption. When you see a placenta which is occupying the lower uterine segment or even covering the os, this is basically our placenta previa. This is our placenta previa. And what is the final image, guys? What is the final image which has been shown here? What do you appreciate here? Again, I have a few days before even I had sent this image in my Insta group as well. So basically, there has been confusion on this image that is it abruption. So if you look closely, you will see that here the placenta, there is no premature separation of blood behind the placenta. It is basically the fetal vessels which are transversing over the internal os. This is basically showing you a case of vasa previa. This is basically vasa previa. So in vasa previa, there are fetal blood vessels which are transversing over the internal os. Yes, very good. Jajaria, yes, you're absolutely right. It is vasa previa. So these are three very important images from antepartum hemorrhage. So let's see a bit more in detail about abruption and placenta previa. Again, a very important question. So this question, which I told you had come for June 2022. Again, in APS, there have been multiple questions, nearly one question every year from the topic of APH. So let's see them. So how do you differentiate between placenta previa and abruptio placentae? So in case of placenta previa, you see that there is profuse fresh bleeding that is coming. So this is basically fresh blood and it is profuse. And usually it is painless. and it is painless. Whereas in case of abruption, you will see that it is dark altered blood. It is dark altered blood. And there can be pain which is associated. So antepartum hemorrhage with complaints of pain. Think about abruption. There has been multiple questions from abruption. So please everyone lend me your ears. So also in placenta previa, there can be warning hemorrhages. There can be small bleeding before the proper heavy bleeding starts. So where is warning hemorrhages seen? Warning hemorrhage is associated with placenta previa. Usually, placenta previa, the bleeding is causeless. There is no antecedent cause as such. So it is usually causeless. It is usually causeless. Whereas in abruption, you can see some antecedent history, such as there could be hypertension, there could be history of trauma. As we discussed in the symptoms, the patient usually has complaining of antepartum hemorrhage, that is bleeding in the antenatal period. Along with that, pain is a differentiating feature which is present in abruption. Once you examine the patient, you will see that the tone of the uterus is increased in case of abruption. The tone is increased in abruption, whereas in case of placenta previa, the tone is normal. In case of abruption, again, sometimes the blood could be collected behind the placenta. That is, there could be concealed bleeding which is happening behind the placenta. And due to this associated bleeding, the height of the uterus might appear more than the period of gestation. That is why the fundal height can be increased. It can be more than period of gestation in case of abruption, whereas it is corresponding to the period of gestation in case of placenta previa. So here it is equal to period of gestation. In case of antepartum hemorrhage, there can be associations such as hypertension or trauma could be associated. The fetal heart rate changes and fetal distress appear very early in case of abruption. So fetal distress appear early. Appear early. So if you get a clinical scenario, look out for these buzzwords: non-case of hypertension, history of trauma, patient has pain and associated bleeding. On examination, you see that the tone of the uterus is increased. You see that the fundal height is more than period of gestation. Very, very key important points which will help you to keep your diagnosis towards abruptio placentae. Yes. So these questions have come in July 2023 as well as Jan 2021 as well. So now tell me, if a patient has antepartum hemorrhage, will you do a per vaginal examination? Will you be doing a PV examination for a patient with APH? Absolutely no. You will not do a PV unless you rule out placenta previa. Because once there is placenta previa and you go in and do a PV, there is going to be massive bleeding. So PV is never done in case of placenta previa. You do a PV in case of abruption only after ruling out and you're pakka sure that it's not placenta previa, then go ahead and you can do a PV in case of abruption. That's fine, but never go for a PV in placenta previa. Yes, exactly. Discadent fusion, you have perfectly told that it is contraindicated. Per vaginal examination is contraindicated in case of placenta previa. Coming to the investigation. So what is the investigation of choice for placenta previa? It is ultrasound, but which ultrasound? It is actually transvaginal sonography. So the ultrasound which is done is TVS. It is TVS. Many students have a doubt. Why? If we are not doing PV, how can I go for a TVS? But in TVS, we do not push the probe through the os. We stop short of the cervix. So it does not cause any further bleeding. So the investigation of choice is TVS. Whereas abruption is basically a clinical diagnosis. That is why they are giving you so many clinical scenarios from abruption. Abruption is basically a clinical diagnosis. That is a clinical diagnosis. So you have a patient who is having this placenta previa and associated bleeding. How are you going to manage that patient? So in the initial stage, if everything is stable, the mother is stable, the fetus is stable, the period of gestation is less than 37 weeks, the patient is not in labor, if everything is all right, you can go for an expectant management. So in placenta previa, the main role is for expectant management. Yes, very good. It is expectant management. So when will you terminate a placenta previa? We'll come to that, but first understand that the management is expectant management. Whereas in case of abruption, once you see abruption, I told you fetal distress can appear very early. There are so many complications associated. We don't wait. The definitive management is delivery. So here I'm going to deliver. We'll go for the definitive management. How will you deliver in abruptio placentae? Is cesarean always required? No. In abruptio placentae, if everything is fine, we can attempt for a vaginal delivery. And in vaginal delivery, if you have to choose, what will you do next? A very frequently asked question. A patient with abruptio placentae who has come to you, whom you have planned for delivery, the first thing that you do is do a artificial rupture of membrane. You go for an ARM or artificial rupture of membrane, followed by the next is oxytocin. So you will have two options. One is ARM, one is oxytocin. What will you choose first? First do ARM, then further on we can go for the oxytocin. So the dictum is vaginal delivery in case of abruption. Whereas placenta previa, the placenta is basically covering the os. Hope you remember the picture I showed you. The os is being covered with the placenta, which is the either it is in the lower segment or it is covering the os. So the baby can't push its way through the placenta, right? Baby can't make a burr and go through this placenta. So we can't attempt for a vaginal delivery in placenta previa. Yes, the dictum in case of placenta previa is cesarean section. It is cesarean section. So I told you that initially I will go for an expectant management and later on for delivery, I'll be going for cesarean section. So who all are the candidates for whom I can go for an expectant management? This includes, just for your easy remembering, remember that everything should be stable and fine. Just remember everything is stable and fine. That means what is stable? The maternal condition is stable. The maternal condition is stable. That is, she should not have excessive bleeding or hemodynamic instability. The fetus is stable. That means there is no fetal distress. No fetal distress. The patient should not be in labor. The patient should not be in labor and the period of gestation should be less than 37 weeks. Once it is 37 weeks, there is no further rule of expectant management. Yes. So this is how you basically differentiate between placenta previa abruption. As you see, once you contrast and learn between these two, it becomes very easy. And many times they will give you points that will clearly help you to differentiate these two scenarios. And the most commonly asked one is clinical scenarios about abruption. So what are the features about abruption? You will see dark, altered colored blood. There can be hypertension associated history of trauma. Tone of the uterus is increased. The associated with that, the patient can have contractions as well. The height of the fundal height is more than the period of gestation. There can be fetal distress, which is associated. Just one additional point. As the tone of the uterus is increased in this scenario, in abruption, the fetal part may not be clearly palpable. Again, a very important key point. It can tell you that the fetal part is not clearly felt. These are the key points about abruption. So what is the first thing that you will do for management of abruption? It's the definitive management, vaginal delivery. The first thing I'm going to do is artificial rupture of membrane, followed by start the patient on oxytocin. Is it clear? Can we move ahead? Students, please be very active in the comment section as well. Do you want me to decrease the pace or anything? You can very well say that to me. All right. Okay. So now let's cover the classification of placenta previa. So there have been questions about the previous classification which is shown here. This is the Brownies classification. The first classification is the Brownies classification. In Brownies classification, again, the types are 1, 2, 3, and 4. 1 means it is just occupying or reaching the lower uterine segment. In 2, it is just touching the internal os. 2 is just touching the internal os. Whereas in type 3, it is covering the internal os, but not when it is fully dilated. So it is covering, or I can say that it is partially covering. It is covering the internal os, but not when the cervix is fully dilated. Whereas in the fourth one, it is completely covering over the internal os. Even when the cervix is fully dilated, the placenta will be covering the os. This is also known as complete placenta previa. So these are the, very sorry, I have some sore throat as well. So you can find some voice issues. Please bear with me about that. I had some URTA recently. Yeah. So in the Brownies classification, we have 1 to 4. In 1, it is in the lower uterine segment. 2 is that just touching the internal os. And 3 is when it is just covering the os, but not when fully dilated. 4 is it is even covering even when the cervix is fully dilated. Now, this classification, though lot of image-based questions have come from this, now there is a newer classification. This is the newer classification. This is basically based on the ultrasound. So normal placenta is usually located more than 2 centimeter from the level of internal os. Whereas again, the two types that is associated with abnormal placentation, one is low-lying placenta, other is placenta previa. If the placenta is less than 2 centimeter from the internal os or from the cervix, it is known as low-lying placenta. So if you see here, it is more than 2 centimeter, it is normal. If it is within 2 centimeter, it is low-lying placenta. And if it is completely covering the cervix and the os like this is the placenta previa. All right. Okay. Coming to a very hot topic, that is MTP, or medical termination of pregnancy. There have been bunch of questions. Again, even in a single exam, there have been multiple questions from the same topic, mainly due to the fact that the MTP amendment which has come up. So let's discuss the important points from here. So previously in MTP, there was requirement of just one medical practitioner up till 12 weeks and 2 medical practitioners from 12 to 20 weeks. But as per the amendment, as of now, we just require 1 till 20 weeks. Please note, very important. From 20 to 24 weeks, there is requirement of 2 registered medical practitioners. So the upper limit is 24 weeks. And we can go for a termination even beyond 24 weeks. Even beyond 24 weeks, termination is possible after the approval from medical board. After a medical board approval, if there is substantial anomalies that can affect the life of the baby, there is substantial anomalies, you can go for an MTP after the approval from the medical board. And another change is that previously the terms such as husband and wife was used. Now just the patient and the partner. These terms have been replaced. The woman and the partner are the terms that is used now. So just one medical practitioner till 20 weeks, 20 to 24 weeks, 2 medical practitioner. Upper limit is 24 weeks, and even beyond 24 weeks, we can do a termination after approval from the medical board. Yes. Coming to the methods of termination. So the methods include, we have the medical method and we have surgical method. So the medical method of termination, previously as per Government of India, the medical method was approved till 7 weeks, and as per WHO, it was till 9 weeks. Now you will see this in many places. Now actually the confusion has been taken away. Government of India has also changed it to 9 weeks. So you just have to remember 9 weeks. So medical method of abortion, or MMA, can be used till 9 weeks. A very frequently asked question, what are the medications that you are going to use? The medicines that you're going to give include 200 milligram of mifepristone, and followed by 800 microgram of misoprostol. Very frequently asked question. Frequently, they will confuse you with the milligram, microgram, and the dose. So, MIFI is in milligram. 200 milligram mifepristone followed by 800 microgram of misoprostol. This mifepristone is given as per oral. Misoprostol has various route. We have per oral, per vaginal, per rectal route, but the preferred one is per vaginal route. So meso is in microgram, mifepristone is in milligram. Mifi is per oral, meso is per vaginal. And what is the gap between these two drugs? I think this is a bit difficult. Am I right? Is it difficult? Is the dose difficult? Please remember that Mifi 200 milligram followed by Meso 800 microgram. So now it won't be difficult. It's very important, frequently asked. So you have to remember this. So just remember, as a patient comes to my OPD, usually we give the patient this tablet first. We ask her to take this tablet. Then we'll call her back after 48 hours, or we'll ask her to self-insert these vaginal tablet after 48 hours. 48 hours. Yes. So after this medical management, after the 9 weeks, the preferred one is surgical management, and the preferred surgical method is suction evacuation. And the question is, till what period of gestation is suction evacuation preferred? This is the preferred method till 12 weeks. Till 12 weeks. Yes, perfect. So many have answered very correctly. I'm very happy that you are so in par with your preparation as well. Yes, it is still 12 weeks. Suction evacuation is done till 12 weeks. So, can you identify what is the instrument shown? This is basically what is this instrument that is shown in the image? Very good. It is an MVA syringe or manual vacuum aspiration syringe. This is the MVA syringe. How do you identify? The characteristic feature is you can see two pinch valves. Look out for these two pinch valves. What is the pressure that is created? It is usually 600 to 660 millimeters of mercury. 660 is the best answer, but usually that's not given, so you can go for 600 as well. Remember, the pressure created is 600 to 660 millimeter of mercury. The capacity of this syringe is 60 ml. And what is the period of gestation till which it can be used? It is till 12 weeks, yes. We can use it till 12 weeks. So MVA syringe is a very important image-based question. So what is the main advantage? This does not require any electricity. I can actually manually cause this suction by just pulling this syringe. So it does not require any electricity. Yes, Adnan, Adnan, the pressure that is created is 600 to 660 millimeters of mercury. So coming to the next topic, that is ectopic pregnancy. What is the most common site of ectopic? Ectopic सबसे ज़्यादा कहाँ पर होता है? Is it tubes, ovary? As you all know, most common site is tube. Everyone knows tube. What is the most common non-tubal site? After tube, what is the second most common or the most common non-tubal site is ovary. It is ovary. The most common non-tubal site is ovary. In the tube, which is the most common site, it is in the ampulla. As everyone has correctly pointed out, in the tube, it is ampulla. And ampulla is also the widest part of the fallopian tube. The most common site of fertilization as well is ampulla. So in the tube after ampulla, the next common site is isthmus. Which is the site of the tube, which is the least common site in the tube to have an ectopic pregnancy. So if you have a look here, this is the ampulla, this is the isthmus, the part which is near this uterus, this is the intramural part or the interstitial part. And this is the least common site in the fallopian tube. It is the intramural or the interstitial part. Interstitial part. The site of the tube which will end the earliest, the first to end is basically this isthmus. It is actually the isthmus which will end the earliest. And the site which has the longest survival is this intramural part. Why is it so? It has some muscle support from the uterus as well. So it does not rupture very early. It is the one that can grow. Actually, even there has been reports where it has gone till the second trimester, up till 16 weeks as well. So the tubal site with the longest cervical is basically the intramural part. All right. Now coming to the management. So let me tell you a very easy method so as to how to manage any patients of ectopic pregnancy. First thing I want you to look for any signs of rupture or not. Always differentiate your patients. First thing you check is, does she have any symptoms of rupture or not? If any signs and symptoms of rupture is present, so then it's an obstetric emergency. Any signs of rupture, what is the first thing that you're going to do? Please comment in the answers. What is the first thing that you're going to do if there is signs of rupture? If there is signs of rupture, what is the first thing that you're going to do? It's not directly surgery. That's why I basically asked that question. First thing is you have to stabilize the patient, give the patient fluids. Often you will find two options. If they are asking you what is the definitive management, that is laparotomy. What is the next step that you're going to take? Or what is the first thing that you're going to do? Whenever such a ruptured patient comes, the first thing I'll do is I'll ask my nurse to put two wide bore IV cannula, start her on fluid, arrange blood, immediately stabilize her. So the first thing is stabilize the patient. Manage the ABC, airway, breathing, and circulation. Then the definitive management is going to be removal of the tube. So the definitive management is going to be, then you will go for surgery. And surgery, again, we have option of laparoscopy and there is laparotomy. There is option of laparoscopy and laparotomy. Is laparoscopy possible in ruptured ectopic? Is laparoscopy possible in ruptured ectopic? A common misconception is once it is ruptured, always go for laparotomy. That's not so. Even we can go for laparoscopy if the patient is stable. If stable, we can remove the tube within 5 to 10 minutes. So why go for an open surgery? If the patient is unstable, you will go for laparotomy. This is basically the algorithm how you will manage these patients. So a patient with ectopic, first see whether it is ruptured and ruptured. Ruptured, your only management is surgery. But the first thing that you're going to do is stabilize with ABC. Start her on fluids, give her blood when it's available. Then the definitive management is surgery. In surgery, if she is stable, laparoscopy, unstable, laparotomy. Is it clear? Is it clear? This is how you will manage her. For an unruptured ectopic pregnancy, now you have your options of medical management and you have the option of surgical management. Yes. Ruptured means, Setu Usman, ruptured means the tube has broken and the products is about to come out. The tube has actually, there will be a small defect in the tube through which it has like opened up and the products are about to come out. The tube is a very small structure. So as the pregnancy grows in this, it won't remain confined in it. Sometimes it can break the tube and come out. It will rupture the tube. That is one meaning of rupture. Okay. So unruptured ectopic like this, you can raise any queries as well. Okay. So in unruptured, the management options include we have medical management and surgical management. Now you have to choose whom to use this medical management, for whom you will do the surgical management. So medical management, as I told you, if it is a ruptured ectopic, I will only go for surgical management. If the patient is unstable, I will only go for surgical management. So in case for a medical, the patient should be stable. It should be unruptured. The patient should not have significant pain or bleeding. If she has significant pain, that means she is about to rupture or she has already ruptured. She should not have no significant pain or significant bleeding. Now, coming to the size of the ectopic should be less than 4 centimeter. There should be no fetal cardiac activity. The size of the ectopic should not be beyond 4 centimeters. It should be less than 4 centimeter. There should not be any fetal cardiac activity. And beta HCG is actually a relative criteria. It is a relative criteria. The level of beta HCG should be less than 5,000. If all these criteria are fulfilled together, only then I will go for methotrexate as medical management. So what is the drug that we usually give? It is methotrexate. So again, there should not be any contraindication for methotrexate. So the final point is no contraindication for methotrexate. If any of these criteria is not fulfilled, now my management is surgical. So if all of them are fulfilled, everything has to be fulfilled together, then only I'll go for medical management. If it is not fulfilled, I'll go for surgical management. Yes. So what is the medicine that I'm going to give here? It is methotrexate. It is methotrexate. So we give the patient methotrexate and we will follow up the patient with beta HCG. So I gave the patient methotrexate. The day which I gave methotrexate is taken as day 1, and again we will do beta HCG on that day. We would do a beta HCG on this day and again repeat on day 4 and day 7. There should be a fall of at least only tubal 1 ruptures. Yes, anyone can actually rupture. Yeah, hello, Dr. Aspiring. Welcome to the session. Yes. So basically, we would be measuring the beta HCG levels on day 1, day 4, and day 7. So the fall has to be at least 15% between day 4 and day 7. A fall of 15% day 4 and day 7. And what is the dose of methotrexate that you give? What is the dose of methotrexate? It is 1 milligram per kg. It can be given as intramuscular or intravenous, and the preferred route is intramuscular. 1 milligram per kg or 15 milligram or 50 milligram per meter square. 50 milligram per meter square. This meter square is the body surface area. So what is the dose? 1 milligram per kg or 50 milligram per meter square. Again, this has been a previous question. All right. So this is about ectopic. So basically, once you remember the algorithm, actually it becomes much easier. So first categorize as ruptured, unruptured, then go in a systematic manner. If it is ruptured, manage with this algorithm. If it is unruptured, then you see if all these criteria are fulfilled. If all are fulfilled, you go for medical. If not, you go for surgical. In medical, the management is basically methotrexate. All right. Now coming to the next part, that is anemia. So in anemia, basically the pregnancy is basically at high risk of developing anemia. Basically, there is hemodilution. The plasma volume is increasing, due to which there is hemodilution which is present. So for a normal non-pregnant female, the cutoff is 12. That is 12 gram per deciliter. The normal hemoglobin is 12 for a non-pregnant state. But in pregnancy, usually there can be some form of anemia, and levels which is from 11 to 11.9 is known as physiological anemia. It is something normal, it is physiological. But if the levels are less than 11, it is known as pathological anemia. And the most common cause of anemia, if they ask you which is the most common cause of anemia, the most common cause is physiological anemia. So mostly in the question, they might not give you physiological anemia. So what is the next most common cause after physiological anemia? The next most common cause is basically the causes which leads to pathological anemia. And the most common among this is nutritional. Among nutritional, the most common is iron deficiency anemia. This is the iron deficiency anemia. Yes, so this is about the anemia. So we have physiological, pathological. Pathological is less than 11. So coming back, yes. So in the anemia, so if I just draw a timeline for your easy remembering, so I told you you have 12, you have 11, then you can again divide it as 10, 7, and 4. Why have I divided like this? So this is basically how you divide anemia. So 11 to 11.9 is known as physiological anemia. 10 to 10.9 is mild anemia. 7 to 9.9, that is just short of 10. 7 to 9.9 is moderate anemia, and less than 7 is severe anemia. Some even classify less than 4 as very severe, but it's enough if you remember till here. So less than 7 is severe anemia. So how will you manage a patient who is having anemia? Again, let me help you with an algorithm. This has been given by the Anemia Mukt Bharat program. It's a simplified version of the same thing. So whenever you get a patient who is having anemia, I want you to look at two things. One is the period of gestation. The second thing is what is her hemoglobin levels. So depending on the hemoglobin level, you will divide it as mild to moderate anemia or severe anemia. This is the first thing that I want you to do. Mild to moderate. Is the patient having mild to moderate anemia or severe anemia? I already told you what is mild, moderate, and what is severe anemia. If the levels are in the range of mild to moderate anemia, next thing is look what is the period of gestation. Less than 34 weeks. If she is less than 34 weeks, I will give her oral iron. If she is if she is more than 34 weeks, I will give her IV iron. Again, severe anemia has been divided as less than 5. If she is less than 5 or between 5 to 7. So what was severe? Severe was definitely less than 7. They have again divided as less than 5 and 5 to 7. If it is less than 5, you will go to the extreme measure. What is the extreme measure? Go for blood transfusion. If it is between 5 to 7, again you divide it as 2. Less than 34 weeks, more than 34 weeks. Less than 34 weeks, you will go with IV iron. More than 34 weeks, you will go for blood transfusion. This is a simplified algorithm with which you can manage any case of anemia, how to manage. So always look at two things. Period of gestation, hemoglobin level. Period of first is hemoglobin mild to moderate, less than 34 weeks, oral iron, more than 34 weeks, IV iron. Severe anemia less than 5, go for blood transfusion. Between 5 to 7, you again divide it as per the period of gestation, less than 34 weeks or more than 34 weeks. Again, my YouTube channel as well, I had given a small video on this, a 5-minute video. You can again quickly recap through it as well. Okay. So is it clear? Is the management of anemia clear? This is how you can easily remember the anemia management with this algorithm. Okay. So now let's discuss some of the physiological changes that happens during pregnancy. So again, these physiological changes have been asked multiple times. I know there is a lot to remember, but this is a simplified box of the major physiological changes that you should must know. All right. So the blood volume. So the question was, Vikas Yadav has asked, when do we give the parenteral iron? Yeah, so parenteral iron is basically IV iron. IV iron is also known as parenteral iron. More than 34 weeks, mild to moderate anemia, I'll give her parenteral iron. 5 to 7, less than 34 weeks, again, I will give her IV iron or parenteral iron. Roy, old gamer, you're making it really interesting. Thank you so much that you're finding it interesting. And I want you to stay tuned and be very active throughout the session as well. All right. So now coming to the changes that is happening. So this again a simplified box of all the changes. So the blood volume, maximum, most of the things are going to increase. You just have to remember the exceptions of what decreases. Okay, so most of the things increases. The blood volume increases. The plasma volume increases. Even the RBCs actually increases. But as the plasma volume is increasing so much, there is going to be a net hemodilution. There is going to be net hemodilution due to which the patient will have anemia. And this anemia is known as physiological anemia. That is why, as due to the hemodilution, the patient can have physiological anemia. What is hemoglobin? It is basically represented as gram per deciliter. The RBCs are increasing, but the deciliter, the volume is also increasing. So the net effect is there is hemodilution, due to which there is physiological anemia. Coming to the platelet. So as there is dilution, even the net effect is the patient is going to have thrombocytopenia. So the patient will have gestational thrombocytopenia. Gestational thrombocytopenia. So I told you, just start with the preconception that everything is going to increase. Blood volume increase, plasma volume increase, RBC increase. So just remember the exceptions. There is hemodilution, physiological anemia. The platelets also will be decreased. There is gestational thrombocytopenia. What about clotting factors? The clotting factors also increases. All clotting factors increases except, very, very important. All clotting factors increases except, it is factor 11 and 13 are the ones which decreases. All right. So it is 11 and 13 which decreases. The fibrinogen increases. ESR, C-reactive protein increases. The cardiac output, stroke volume, heart rate, all these increases. But remember, what happened to the blood pressure? Blood pressure actually decreases. Under the effect of progesterone, there is going to be under the effect of progesterone, there is going to be vasodilation that happens, due to which the blood pressure actually decreases. The blood pressure decreases. The protein levels increases. All proteins increases. So all protein means including globulin is a part of protein. Or when the globulin increases, except, again an exception, except the albumin decreases. The albumin decreases. The glomerular filtration rate, net blood volume is increasing, the filtration through the kidneys are increasing, glomerular filtration rate also increases. Yes. All right. So is it clear? These are the various changes that happens. Okay, yes, Vikas has rightly answered that. That's the albumin, which is actually decreasing. Very good. All right. Okay. So can we move on to the next slide? Yes, pregnancy is aggressive coagulation state. Exactly, Roy. So actually, in pregnancy, everything pushes the woman towards having a thrombosis or having a clot. So just remember all the clotting factors, everything related to clotting actually increases, except factor 11 and factor 13. Very important. This has been asked in NEET as well. All right. Coming to diabetes. So again, diabetes is a very interesting topic. The previous question which came and everyone make has some confusion is, when do we screen for diabetes? Can you comment? When do you screen for diabetes? When do you screen for diabetes? Yes. So the main misconception is that we screen only at 24 weeks. That's a misconception. No, that's only for the Western guidelines. As per the Indian guidelines, we are asked to screen at the first visit itself. At the first visit, then again at 24 to 28 weeks. So first at the first visits itself, then at 24 to 28 weeks, because our Asian population, the ethnicity, everything makes us more prone towards having a diabetes. First visit, then at 24 to 28 weeks. So we have the one-step screening, which is given by the DIPSI, that is the Government of India. And we have another one-step screening, which is given by IADPSG. So as per the IADPSG, in both of these, we give 75 grams of glucose. In IADPSG, I'm going to give the patient this in a fasting state. And again, I will check at 0 hour, 1 hour, 2 hour values. This is extremely important. Why is it so? They will give you clinical scenarios as well, in which they will be giving you these cutoffs and they will ask you, how will you, is the patient diabetic? There could be direct questions, or many times there have been so many applied questions in FMG as well. The questions are, how will you manage the patient? So they have gone one step further and asked you the management indirectly by giving you these values. So it's extremely important you are thorough with these values. What are the values? The 0 hour value is 92, 1 hour value is 180, and 2-hour values are 153. 92 gram per deciliter, 180 is the 1-hour value and 2-hour value is 153. If any one is abnormal, you will call the patient as GD. So in Government of India guidelines, it is much simpler. They don't want the patient to be fasting or anything. It's actually for low resource settings as well, where the patient comes itself, irrespective of whether she is fasting or not, you just give her 75 grams of glucose. Just catch hold of her, give her the 75-gram glucose, and then test her after 2 hours. Test her after 2 hours. If the levels are more than 140, if the levels are more than 140, then you will call the patient as GDM. So are you thorough with the cutoffs? This is very important for IADPSG, that is the 75 grams, also known as 75-gram OGTT. The cutoffs are 92, 180, 153, and the Government of India, the DIPSI one, it is more than 140. DIPSI is irrespective of fasting status, whereas the 75-gram OGTT given by IADPSG, we do in fasting status. So, what is the implication of this? The implication is about the management. So, there is another entity known as overt diabetes or pre-gestational diabetes. Is it same as GDM? Very important concept. Everyone, please be with me here. Very important. So, is GDM same as overt diabetes and pre-gestational diabetes? No. This is basically the levels are actually in the non-pregnant state. So, all the levels are so high. They are in the non-pregnant state. What is the non-pregnant state levels which you studied in medicine? What is the cutoff for a person who is not pregnant? When will you call the person as diabetic? The fasting when it is more than 126. Any random blood sugar more than 200. Postprandial levels more than 200. HbA1c more than 6.5. And DIPSI levels, when I do DIPSI, even that is more than 200. So you have to just remember three things here. You might notice there are three 200. So all after food wala ones are 200 and the fasting one is 126 and HbA1c 6.5. These 126 and 200 are the must know values. Let me tell you the question that they have given. So you have a patient who had undergone a GTT test. Now the GTT levels are fasting is 95. The after post 1 hour level which you got is 210 and the 2-hour value is 180. How will you manage this patient? So basically, when such a scenario comes, first thing I want you to do is divide the patient as GDM or overt or pre-gestational diabetes. How does the management differ? So if the patient is just GDM, I'm not that tensed. I will be relaxed and we'll just start the patient on diet. Aram se we can just start the patient on just diet. We need not hurry. All right, so first we'll start her on diet, and this is known as MNT, medical nutritional therapy, which includes the diet as well as exercise. And after 2 weeks, I will again reassess. If the patient is well controlled, let's continue with the diet. If the patient is not very well controlled, then I will go to the next step, that is, we'll go for the medical management. But if the question is in the range of overt diabetes, what is overt diabetes? Please revise with me what is overt. The fasting is more than 126, postprandial levels are more than 200, the random levels are more than 200, HbA1c is more than 6.5. इसमें तो I'm not that relaxed. मैं उतना आराम से नहीं बैठ सकती, right? Once it is overt, I can't just give her this diet and wait for it. I'm going to treat it more aggressively and we'll start her directly on the drugs. We'll start her on medical management. I'll start her on medical management. Apart from this, yes, I will ask her to take diet. I will ask her to do exercise. But the main thing is medical management. Congenital malformation, yes, exactly. Discordant fusion, congenital malformation risk is there. There are so many complications like risk of abortion, congenital malformation. All these are increased as associated with this overt diabetes. So I won't be that relaxed in case of overt. I'll directly attack the patient with attack the diabetes with the medicines. Okay, Dhruvid has told he has missed a part of it. Don't worry, Dhruvid. You can see the videos. It will be available in YouTube as well. So I hope you won't miss the further session. Yes, sacral agenesis, Vikas has rightly pointed out. The most specific anomaly that is associated is sacral agenesis. We'll come to that. Let's finish this management part. So, in case of overt diabetes, I will give the patient medical management. Along with that, I will add some diet, some exercise. But the question that came in December 2020 asked you to specifically choose one. There was the option of insulin, there was option of OHA, there was option of diet, there was option of exercise. What is the drug of choice in case of diabetes in pregnancy? What is the drug of choice? What is the drug of choice that you're going to give in this scenario? Insulin, perfect. It is insulin. Insulin is safe for the baby, it does not cross the placenta. So the management is basically insulin. Very good, excellent. It is insulin. So what was the answer? So if I give a clinical scenario, postprandial levels are 220, fasting levels are 130. You will all think about in terms of overt. Now your first management is insulin. It is insulin. Along with that, just like some spices which we add, like the masala part, we can add some diet, some exercise, but the main core management is insulin. The pillar is insulin. All right, this is how we are going to basically manage it. So, coming to the other complications that can happen in overt. So, they are at increased risk of abortions, they are at increased risk of anomalies. The most common anomaly is cardiovascular system anomaly, which is VSD. The most specific anomaly is sacral agenesis, also known as caudal regression syndrome, also known as caudal regression syndrome. So if a further scenario comes on this, you should be able to answer. So the basic problem students face this, they don't divide it. First, divide it as whether it is GDM, whether it is overt. Once you go in this stepwise manner, it becomes extremely easy to manage the scenario. So in ectopic, I told you how we will go. First divide as ruptured, unruptured. Then again, if it is unruptured, medical, surgical, rule out the possibilities. If it is anemia, I told you, look at two things, period of gestation and the hemoglobin level. Divide it, make that algorithm and manage it very easily. If it is diabetes, again, divide it as GDM or overt. GDM means just the diet, medical nutritional therapy, exercise. Then after 2 weeks, reassess and we can go for insulin. If it is overt, directly go for the medical management. This is basically a summary of how you are going to manage. All right. Is it clear? Yes, Elon Musk, very interesting name, has asked me actually what's the most specific is the transposition of great vessels. Am I wrong? You are not wrong. The most specific cardiovascular defect is transposition of great vessels. But the most specific anomaly overall. So if the question is just asking you what is the most common anomaly, most specific, not most common, most specific anomaly, that is sacral agenesis. But if they are specifically asking you what is the most specific cardiovascular system abnormality, then the answer is transposition of great arteries. Can you see the play of words there? If they specifically ask you most specific cardiovascular system anomaly, it is TGA, but most specific overall is this one, sacral agenesis. I hope it is clear, Elon Musk. How many classes for whole obs and gynae? So this is a rapid revision, but in the app, it's actually it's not very vast. You'll be able to cover very easily, and we have rapid revision sessions as well. So you can, as the time is less now, you can go through that rapid revision part as well, which is available. Yes, Dhruvid, there is a role of aspirin for the prevention of preeclampsia. So, for patients who are at high risk of preeclampsia, we can give aspirin for prevention. And the drug, the dose that we give, it is usually low dose aspirin. It is 150 milligram, which is given at the night time. This low dose aspirin, which is given for prevention of preeclampsia. All right, let's continue. Yes. So coming to hypertension. So again, this is basically a slide from my YouTube session as well. So this is actually a simplified way in which you can remember the classification of hypertension. Do not worry, I'll explain it to you. So hypertension, basically we have four types, actually five types. So the types include, we have the gestational hypertension, chronic hypertension, preeclampsia, and chronic hypertension with superimposed preeclampsia. So, what is basically hypertension? Hypertension is systolic blood pressure more than or equal to 140, diastolic blood pressure more than or equal to 90. So, I will call the patient is having a gestational hypertension if this high blood pressure is noticed first more than 20 weeks period of gestation and it comes back to normal within 12 weeks postpartum. So, both of these should be fulfilled together. This is why the plus sign. She should have blood pressure only after 20 weeks and this blood pressure should come back to normal within 12 weeks. अगर ये दोनों एकदम से fit हो रहा है, then we'll call it as gestational hypertension. If any one of this is not fulfilled, I'm going to call it as chronic hypertension. That is, if the blood pressure is raised less than 20 weeks and it does not come back to normal beyond 12 weeks postpartum, it is chronic hypertension. If these patients are associated with proteinuria or evidence of end organ damage, then we will call it as preeclampsia or chronic hypertension with superimposed preeclampsia. So let me explain it. So if a patient who is having gestational hypertension develops proteinuria, then or end organ damage, I will call it as preeclampsia. If a patient who is having chronic hypertension develops proteinuria or end organ damage, I will call it as chronic hypertension with superimposed preeclampsia. Is this clear? This classification is as simple as this, but there have been so many questions on this. One question is, you have a patient who has a blood pressure of 150 over 90. What is the next thing that you're going to do? First thing that you do is check for proteinuria. First thing is you will do a simple dipstick test. You will ask the patient to urinate on a small dipstick and we will check for the protein which is present. So that's one question. If a patient has hypertension along with evidence of protein, what is the diagnosis? It is preeclampsia. Gestational hypertension with proteinuria, it is preeclampsia. So again, there can be scenarios in which they will give you such scenario and ask you to identify. So let me ask you one scenario like this. So you have a patient who had high blood pressure at 22 weeks. You followed her up. At 13 weeks, she has come. Still, her blood pressure is raised. There is no evidence of proteinuria, no evidence of end organ damage. What is your diagnosis? Let me check if you have understood this. So again, let me repeat. She has hypertension. It is diagnosed at 22 weeks. At 13 weeks postpartum, still she has high blood pressure. No proteinuria, no end organ damage. What is your diagnosis? Excellent, very good. So where are we? So we are in this part of the graph. So here blood pressure goes had happened more than 20 weeks, but it is still present beyond 12 weeks. So this is present. So I'm on this side. There is no proteinuria, no end organ damage. So basically my diagnosis is chronic hypertension. This is one type of question which commonly comes for the exam. They are very frequently, I think this is a topic loved by all examiners, very frequently asked question is about HELP syndrome. So HELP is actually right there staring at your face. The answer is right there. Just expand the letter HELP. H stands for hemolysis. EL is for elevated liver enzymes and LP is for low platelets. So if they give you a scenario in which there is evidence of hemolysis, the liver enzymes are increased. Increase means it is more than 2 times. More than 2 times in pregnancy, normal is 35. So more than 70. SGOT, SGPT levels are more than or equal to 70. The platelets are low. Platelets are low means less than 1 lakh per millimeter cube. Evidence of hemolysis means it could be evidence by increase in bilirubin, or increased LDH, evidence of hemolysis in peripheral smear. All these think about hemolysis. If these three scenarios are fulfilled, your answer is HELP syndrome. Very, very important. If three are fulfilled, you will think about HELP syndrome. Now, what is the management of HELP syndrome? So this HELP syndrome had come in June 2021 as well. how there was basically a clinical scenario in which these findings were given. That is raised LDH, raised LFTs, the patient has hypertension, the platelet was low. What is your diagnosis? It is basically HELLP syndrome. The management of HELLP syndrome is once there is HELP, you don't wait, you basically terminate. Okay, someone is screaming at you for help. You won't just wait and watch that patient, right? You go and give your help to that person. So just help the person and deliver her. All right, so you are going to deliver. The management is termination of pregnancy. In the termination, prior to termination, you can add some few more things like antihypertensive, like magnesium sulfate, like steroids if the baby is premature, but the definitive management is termination of pregnancy. Is this clear? Yes. So, what is the most dominant theory for the etiopathogenesis? There is basically defective vascular remodeling. Basically, the trophoblastic invasion does not happen. There is defect in the trophoblastic invasion, due to which, usually, due to the trophoblastic invasion that happens in two waves. The spiral artery, which are actually small, tight arteries like this, the spiral arteries, after the trophoblastic invasion has happened, they will become low resistance, high capacitance vessels. The capacity actually increases. They become low resistant, high capacitance vessels. The first problem is that there is defective vascular remodeling that happens, due to which this happens. Yes. Now coming to the management of preeclampsia. So the management, the basic and most important management is you are going to give the patient medication so as to decrease the blood pressure. We have to prevent any seizure from happening, and we will have to terminate the patient depending on the period of gestation. So the antihypertensive that you give is the drug of choice is labetalol. It is labetalol. Previously, there was no doubt on this. It was labetalol. But what happened is, in the Williams 26th edition, even they told that even labetalol can cause IUGR. Most of the beta blockers can cause IUGR, but labetalol was less associated with that. But William 26th edition has told that even labetalol can cause IUGR, and that is not really that safe of an option. So, if you get a question and you have to choose one drug, you can go ahead with labetalol. The other drugs which are there include nifedipine, which is a calcium channel blocker, and alpha methyl dopa, which is not being used now. Previously, we had this alpha methyl dopa. All right. So as to prevent seizure, the medication that is given is magnesium sulfate. Magnesium sulfate, a very important drug. The drug that is given to prevent seizure is magnesium sulfate. The magnesium sulfate, we have the intramuscular regimen and the intravenous regimen. We'll come back to magnesium sulfate. It's a very important topic actually. We'll come back to magnesium sulfate. Next is steroid. If the baby is premature, if we have to terminate less than 34 weeks, we will give the patient steroid for lung maturity. Lung maturity. In the topic of preterm labor, I will teach you the various steroids. We have the option of dexamethasone, betamethasone, how to deliver that, we'll study that. So just understand that for prematurity, I'm going to give the patient steroid. Finally, termination. So termination, if again, the termination depends upon whether the patient has preeclampsia, which is non-severe, or it is severe. If it is severe, we will terminate at 34 weeks. If it is non-severe, we can go till 37 weeks. This is a simplified cutoff which you can remember. Non-severe, remember 37 weeks. Severe, only till 34 weeks. Now coming to the important drug, that is magnesium sulfate. So will I just give magnesium sulfate to all patients who are having hypertension? No. We'll give for those patients who are at risk of having eclampsia, or patients who are already having eclampsia, or who are having severe preeclampsia. So the indication include severe preeclampsia, eclampsia, as well as evidence of Impending eclampsia. Impending eclampsia. What is meant by this evidence of impending eclampsia? The patient will complain that the patient is having headache. There is headache. There is blurring of vision. The patient can have epigastric pain, vomiting. These all signs are suggestive of impending eclampsia. The patient might throw a fit at any time. Headache, epigastric pain, blurring of vision, and vomiting. So, what are the regimens? So, as we discussed, we have the intermittent intramuscular injection, which is the Pritchard regimen. It is a Pritchard regimen, and you have intravenous infusion. The commonly used intravenous infusion is Zoospan regimen. It is Zoospan regimen. So, after starting this magnesium sulfate, how long are you going to continue it? Can you comment? How long will you continue this magnesium sulfate? The duration that we are going to give this magnesium sulfate is basically for 24 hours. It is 24 hours since delivery or since the last seizure, whichever is later. So it is for 24 hours since last delivery or seizure until the last seizure, whichever is later. All right. So the problem with this magnesium sulfate is that it has a very narrow therapeutic range. Slightly we exceed this range, the patient can have toxicity. And what is the therapeutic range of magnesium sulfate? It is 4 to 7 milliequivalent per liter. It is 4 to 7 milliequivalent per liter. What are the signs of toxicity? So whenever we give this magnesium sulfate, we are all alerted. We check for a lot of things. So the first thing we usually like run for when we start this magnesium sulfate is we go for a knee hammer actually, because I have to check for the knee jerk or the deep tendon reflexes. The first thing that goes is or is affected due to the toxicity is knee jerk. It is knee jerk, followed by respiratory depression. Very good, excellent. Respiratory depression. And finally, what's the final thing? It's the heart which is affected. This cardiac arrest. So first thing is loss of knee jerk, followed by respiratory depression, and finally there can be cardiac arrest as well. So there is some drug which has so many problems. So we should need some antidote so as to negotiate or to overcome these problems in case these complications happen. And that antidote is our calcium gluconate. So this calcium gluconate is the drug that is given as an antidote. The dose is 10 ml, 10% over 10 minutes. It's calcium gluconate. So if you want, I can just tell you the Pritchard regimen, the dose as well. So in Pritchard regimen, we have initially a loading dose followed by maintenance dose. The loading that dose that we give is 14 gram. It is 14 gram, followed by maintenance dose of 5 gram intramuscular each buttock every 4 hours. Every 4 hours. And as you all know, I won't give this 14 gram as such. Ekdam say, we won't give it together. I'm going to divide it. This 14 gram is going to be divided as 4 gram IV and 5 gram each buttock. So 5 into 2, 10, 10 plus 4, 14. That is how we come to 14 gram. Yes, 4 plus 5 is the total dose. So yes, someone has commented, happy birthday, ma'am. Oh, thank you so much, but it's not my birthday, but still thank you so much for the wishes. You are 2 months late. All right. Okay. Yeah, we'll cover most of the OBG important points here. Yes. Okay, happy anniversary. Thank you. You are 1 month early, but still thank you, Jimmy. Nikhil Singh, thank you so much. Such a lovely comment. Of course, you should become a gynecologist. Please do come to this field. Yes. Thank you, Nikhil. All right. So, is it clear? Is magnesium sulfate clear? A very important topic. So the indications, the regimen, duration, therapeutic range, toxicity, antidote, all these are very, very important. All right. So next coming to gestational trophoblastic disease or GTD. So GTD, basically there are two types. We have the complete mode and partial mode. So what is the basic difference between this complete mode and partial mode? So in complete mode, basically there is an egg, there is an ovum, but that ovum is empty. There is nothing inside. You have an empty egg that is fused by a sperm. And after this fusion has happened, then there is duplication of sperm. Then there is duplication of sperm, empty egg and a sperm which has duplicated. So what is the final product? It is diploid. And the most common one is 46XX is the most common karyotype. Whereas in partial mode, in this, there is one egg which has been fertilized by two separate sperms. So the final product is actually triploid. And the most common one among that is 69XXX. So just an easy clue for you. Just remember that one with the more X's is the more common one. 46XX, 69XXX are the most common ones. You need not by heart that. Just remember the XX ones. Maximum X is most common. So this complete mode is actually has diffuse trophoblastic hyperplasia. There is hydropic degeneration of villi. There is diffuse hydropic villi which is present in this. That is why due to this hydropic villi which is present, it gives a appearance like a snowstorm, just like a snowstorm. And it is known as snowstorm appearance. This image is very, very important. Snowstorm appearance. They will give you this image and ask you for a diagnosis. So when you see such small, small cystic areas, which is basically due to the hydropic villi, which is there, you will diagnose this as a complete mode. If they give you two options, one is partial and complete mode, you will go for complete mode. If they only give you an option as GTD, or gestational trophoblastic disease, or even molar pregnancy, you can choose that answer. The perfect answer is complete mode, snowstorm appearance. So again, in my Insta as well, I have given that snowstorm appearance, the storm as well. You can just check it out as well. All right. So in partial mode, basically there is some component from the father as well as from the mother. So in this, there can be some fetal tissue that is present. So the question is giving you fetal tissue is present. Instead of directly giving you fetal tissue, they will give you fetal RBC, fetal membrane, decidual membrane. Any part of fetal tissue is present. Understand that they are basically talking about partial mode. They are talking about partial mode. What is the management of choice? Management is suction evacuation. Management is suction evacuation. Suction evacuation. And how will you follow up this patient? How are you going to follow up? Again, all these are repeatedly asked questions. The follow-up is basically using a hormone that is beta-HCG. So I am going to repeat this beta-HCG weekly till negative. Once it is negative, we will follow up for monthly. We will follow up with monthly beta-HCG for at least 6 months. Yes, the main management is with this beta-HCG. Yes, Nikhil Singh is absolutely right. It's not that partial mode presents as missed abortion, but due to this fetal tissue which is there, missed abortion is a differential diagnosis for the ultrasound findings of a partial mode. So in partial mode, the findings can be similar to a missed abortion. So USG mimics a missed abortion in case of partial mode, whereas in complete mode, you have the snowstorm appearance. Is this clear? I'm so sorry for my voice. I recently had this throat infection due to which it's slightly, so much cough and sore throat. All right. So is it clear? Yes. So then why are we following up these patients with beta-HCG? Because they have a chance of transforming into this GTD can form GTN. That's our cancer, gestational trophoblastic neoplasia, which includes this choriocarcinoma and invasive mode. So among complete mode and partial mode, this complete mode has higher risk of malignancy, higher chance of conversion to malignancy. This approximately 20%. You need not remember the value. Just remember that complete mole has higher risk of transformation into malignancy. So partial mole, actually the risk is nearly 5%. So actually we used to remember is that partial is punch. Punch is partial. So 5% is the risk of malignancy with partial mole. Get laryngoscopy. No, no, Nikhil, just a URT. So much URT in the hospital as of now. No problem for me as such. Yes. Rhinitis and all those. Yes. All right. Okay. So now let's move on to the next topic, which is aneuploidy screening. A very important favorite topic, aneuploidy screening. So basically, so as to assess for any chromosomal problems, such as the baby, it could be any problems, the chromosome structure, number, the common ones are like our Down syndrome. So as to screen for this, we have something known as aneuploidy screening. And in aneuploidy screening, we have the first trimester screening and the second trimester screening. The first trimester screening includes, we have the biochemical test as well as the ultrasound. In biochemical test, we do the double marker. In ultrasound, we go for NT-NB scan. Yes. In double marker, the two hormones which is tested, the two markers which is tested is beta HCG and PAP-A. PAP-A. The scan is basically showing you the NT-NB scan. This translucent area which is there behind the nape of neck is the nuchal translucency. And the bone which is present here, then is the nasal bone. We look in the scan for the nasal bone and nuchal translucency. Nuchal translucency more than 3 millimeter is always abnormal. So when do you do the double marker? This is done between 11 to 13 plus 6 weeks. 11 to 13 plus 6 weeks. When do you do the NT-NB scan? It is done between 11 to 13 plus 6 weeks. So the question, one question that was asked was a direct question. When is NT-NB scanned? And direct question 11 to 13 weeks. Second question is, when do you do the quadruple marker, which came for the last exam in July 2023? When do you go for the quadruple marker or even the triple marker? They are basically done in second trimester. So in second trimester, we have triple marker and you have the quadruple marker. So to have to easily remember this triple marker, you just remember A, B, C. You just remember A, B, C. A is for alpha fetoprotein, B is for beta HCG, and C is for unconjugated estriol. It's not conjugated, it's unconjugated estriol. Alpha fetoprotein, beta HCG, and unconjugated estriol. In quadruple marker, there is finally a fourth one, which is our inhibin. This is the biochemical markers, and in ultrasound, again, here also we have an ultrasound in which we will be looking at a lot of soft tissue markers. Soft tissue markers, yes. So you have alpha fetoprotein, beta HCG, unconjugated estriol in case of triple marker, and in quadruple marker, we have an extra one, which is inhibin, which is measured. So let me tell you an easy way so as to remember this. Just remember beta HCG, B is big, I is increased. So beta HCG is big or increased in case of Down syndrome. Only they will ask you about Downs mostly. So in Downs, beta HCG is increased and inhibin is also increased. Beta HCG is big. The others are decreased. So alpha fetoprotein is low, unconjugated estriol is low. These two are low. Similarly, even in double marker, B is big, beta HCG is big, PAP-A is decreased. Is it clear? All H will increase. Yes, correct. All H. H is high. You can remember H is high. Beta HCG is high. Inhibin is increased. Rest all are less in case of Down syndrome. All right. So, suppose a patient has, is it clear? A very important topic actually. So many questions on aneuploidy screening. So you do the triple marker, quadruple marker in the second trimester. In the first trimester, I will do the double marker along with NT-NB scan. So suppose this aneuploidy screening is showing high risk, or if it's showing some abnormality, it could be high risk, intermediate risk. What is the next thing that you're going to do for such a patient? We won't directly terminate or we won't do anything for the pregnancy. I'm going to do a definitive test. And the definitive test is basically amniocentesis and CVS. So in this, basically, I'm going to test for the karyotype, whether it is actually present or not. In CVS is basically done between 11 to 13 weeks. CVS can be done beyond 10 weeks, but the ideal time is between 11 to 13 plus 6 weeks is the ideal time where you'll go for this testing. Yes. Whereas in amniocentesis, I'm going to take out this amniotic fluid and send it for testing. It can be done beyond 15 weeks, and the ideal time is between 16 to 18 weeks. What is the advantage of doing the CVS? So basically, when such question comes for you, a patient is having high risk of aneuploidy. This double marker, something is done, it is high risk. Next thing that you check is period of gestation. If the period of gestation is coming here, you will go for CVS. If it's a later period of gestation beyond 15 weeks, you will go for amniocentesis. The main advantage of CVS is that it is going to give you an early diagnosis. It gives you an early diagnosis. But the main disadvantage is that it has higher risk of abortion. Higher risk of abortion. Just the opposite for amniocentesis. So what will be the disadvantage? Late diagnosis. What would be the advantage? It has less risk of abortion. It has less risk of abortions. Yes. This is basically about CVS and amniocentesis. Now coming to the next topic, that is non-stress test, NST or non-stress test. So NST is basically, in NST, we look at three things. We have the baseline heart rate, the beat-to-beat variability, the presence of acceleration. And fourth thing is there should not be any decelerations. What is the normal baseline heart rate? It is between 110 to 160 beats per minute. And the normal variability is between 5 to 25. If there are at least two accelerations over a period of 20 minutes, we call it as reactive. So there should be two accelerations over 20 minutes. And there should not be any decelerations. So now you will comment where these three types of decelerations are seen. I've given you three types of decelerations. There can be early deceleration, late deceleration, variable deceleration. Where do you see each of these decelerations? Where do you see each of these decelerations? Yes, correct. Where do you see early deceleration, late deceleration, and variable deceleration? Early decelerations are associated with head compression. Late decelerations are associated with placental insufficiency. Also known as uteroplacental insufficiency, and variable decelerations are associated with cord compression. They are associated with cord compression. So these are the three types of deceleration that you see. So you have early deceleration, head compression, late deceleration, uteroplacental insufficiency, variable deceleration in cord compression. Is it clear? All right. So let's now, yeah, okay. So we are near the half time. So let's take a break of 15 minutes and again meet. Do you want a break? Okay, do you want me to make those graphs? Definitely. Okay. So if you want to see the graphs, how it looks. So initially, when you see, there are two graphs which are there. Below, you have the uterine contractions which are there. And above that, you see the fetal heart rate changes. If it is just a mirror image like this, it is completely corresponding. The onset of contraction is corresponding to the onset of deceleration. The peak of contraction is corresponding to the nadir of deceleration, and the ending of contraction corresponds. So mirror image, it is early deceleration. In the next one, it is late. The deceleration are late. That means the deceleration start after the onset of contraction, and it is there even after the contraction has ended. Then the deceleration is ending. Again, similarly, if I draw here, it will look something like this. So there is a phase shift which is there. This is basically the late deceleration. Finally, you have the variable deceleration, which has no association. Variable deceleration is going on its own way, that contractions are going on its own way. So deceleration has its own way and the contraction has its own way. There is no relation between both these, and that is suggestive of a variable deceleration. This is how you differentiate all three graphs. No, actually, yeah, no, the session is not over. Early deceleration, yes. Early deceleration is seen in normal pregnancy also. Yes, absolutely correct. Ma'am, here cardio CTG ka findings are absolutely. These are findings with CTG. So basically, there are two things. You have NST and you have CTG. The basic difference between this is CTG is done during labor, where we check also for the contractions. And cardiotocography, the term toco means contractions. So whenever you see two graphs, one is the contraction graph and one is the fetal heart rate graph, that is a CTG, which is done in labor where there are contraction. Whereas non-stress test is done basically when there is no contraction. The patient is not under any stress. That is NST. So if you see two graphs like this is basically CTG. So that's the difference between CTG and NST. All right. Okay. Okay. So finally, as the variable deceleration, the graph will look something like this. You have the contraction graph and you have deceleration, which has no association. It is going something. There is no, absolutely no relation with the contraction which are present. All right. So moving on. Next is biophysical profile. So in biophysical profile, we basically look at five things. The five things which are looked in case of biophysical profile includes the movements of the baby, the movements, next is tone, breathing, non-stress test, and the like. These are the five things that you check for in case of a biophysical profile. Among these, each of these have a component. Each of these components have a score of 2 each, and the normal BPP is 10 by 10. The single most important one among this is basically the Likert. The Likert. And the Likert which we measure here is single deepest pocket, SDP. So in the topic of AFI, I'll tell you what is SDP or single deepest pocket. In case of modified biophysical profile, we look at AFI and the non-stress test. These are the two things that we check in modified biophysical profile. So as we are discussing, we have SDP, single deepest pocket, and AFI. So as to understand this, let me tell you a bit more about amniotic fluid index. Yes, Jimmy has absolutely rightly mentioned AFI, modified is AFI and NST. Perfect, Jimmy, that's correct. So yeah, Elon Musk had asked about the sinusoidal pattern. Sinusoidal pattern is something like this. You see a sine wave pattern. The fetal heart rate is going like this in a sine wave pattern. It is oscillating like a sine wave. And this is basically seen in case of anemia, in case of fetal anemia. Sinusoidal pattern, as you asked. Sinusoidal pattern is seen in fetal anemia. So they need not directly give you fetal anemia. Instead, they can give you some conditions such as RH isoimmunization, where you can find fetal anemia. Yes. Now, coming to amniotic fluid. So, the main source of amniotic fluid at term, a very important and frequently repeated question. What is the main source of amniotic fluid at term? What is the main source? Aspiring doctor, reply me now. Aspiring doctor, have you asked any question? I missed it, I think. Okay, okay, your question was, will whole OBG be covered? Yeah, most of the OBG, or at least all the PYQs and important parts will be covered. Yes. Good evening, Ritvik. Yes. So everyone, you have answered it correctly. The main source of amniotic fluid is basically the fetal urine. It is the fetal urine. Again, there have been two, three questions from this. The main source of amniotic fluid at term, the main source of amniotic fluid beyond 20 weeks is all fetal urine. And it is maximum at 32 to 34 weeks. Maximum at 32 to 34 weeks. Yes. So, in case of ultrasound, in the AFI, you are going to measure amniotic fluid index means you are going to measure the all four quadrants. And the normal AFI, the level is between 5 to 25. The normal single deepest pocket, the normal levels are between 2 to 8. If the levels are below this, we'll call it as oligohydramnios. If the levels are less than this, we'll call it as oligo. And if it is beyond this, we'll call it as polyhydramnios. And if there is an oligohydramnios, the most common cause of oligohydramnios, most common cause of oligohydramnios, what do you think would be the most common cause? The most common source is fetal urine. So the most common cause of oligohydramnios is renal abnormalities such as renal agenesis is the most common cause. Yes, very good. Renal agenesis is the most common cause of oligohydramnios. Now coming to twin pregnancy. So the twins can be, you have the dizygotic twin and the monozygotic twins. So among the various twins, the most common is actually the dizygotic twins. And the dizygotic twins lead to dichorionic diamniotic twin. That is why the most common twin overall is dichorionic diamniotic twins. The monozygotic twins can be again, they can again differ depending on when the division is happening. If the division is happening within 4 days, if the division happens within 4 days, they will divide completely into two. That is, they will split into dichorionic diamniotic twin. If the split is happening between 4 to 8 days, they will develop into monochorionic diamniotic twin. Whereas if the split is beyond 8 days, there will be just one amniotic sac, one placenta, that is monochorionic, monoamniotic. Beyond 12 days, there would be joined, that is the conjoined twin. They will be joined, conjoined twin, the Siamese twins. The split has not happened till the 12th day. The split is beyond 12th day. Again, this has been a recent question as well. If the split happens at 9th day, what would be the type of twin? This monochorionic, monoamniotic type of twin. So, yes, any questions? Is it clear? Okay. Yes, can esophageal atresia cause oligohydramnios? No, whenever, so basically what you have to understand is the swallowing actually causes the fluid to decrease. Once the main source of production is from the kidney, the main source of resorption one is the swallowing as well. So whenever there is a problem with the swallowing, such as esophageal atresia, duodenal atresia, all these problems will actually cause increase in LICA rather than decrease in LICA. Poly rather than decreased. Yes, Nikhil has asked me what is the most common conjoined twin. Yes, Nikhil, we are coming to that. So the most common twin is dichorionic diamniotic. The most common cause of monozygotic twin. What is the most common monozygotic twin? The most common monozygotic is monochorionic diamniotic. And the most common conjoined twin, the most common conjoined is thoracophagous. They are join at the level of thorax. Thoracophagous is the most common type of conjoined twins. Yes. Yes, Elon, you are right. It will lead to poly. Yes, esophageal atresia can lead to polyhydramnios. Okay, all right. Okay, so we'll take a very quick break of just 5 minutes and we can again meet back in a 5 minutes break time. Okay. Hello, friends. So let's continue with the session. All right. So now let's discuss about the various types of pelvis. So again, the types of pelvis has been asked twice. Again, it's important. So the types of pelvis, we have the gynecoid, anthropoid, android, platypaloid. Let me tell you some key words so as to identify these types of pelvis. Yeah, thank you. Thank you. You're welcoming me back. Yes. So, yes. So the types in gynecoid, basically, you look at the inlet so as to identify these four types of pelvis. In gynecoid, you see a round type. The inlet is basically round. In case of an anthropoid type of pelvis, it is anteroposteriorly oval. It is AP oval. In case of android, it is heart shaped. It is heart shaped. In platypaloid, it is flat. Flat. Just remember that. Platypaloid is flat or it is oval transversely. So the question that they gave previously was they showed an image of this gynecoid pelvis, which is basically a round pelvis, and asked you to identify these pelvis. Yes. So which among the following is most favorable for delivery? The most favorable and the most common one is basically our gynecoid type of pelvis. This android type of pelvis is most commonly seen in males and it is the least favorable type of pelvis. It is the least favorable type of pelvis. Now coming to occipito-posterior position. There are two questions that come from this. One is they ask you most common pelvis associated with OP position or the occipito-posterior position. The second question is where they ask you which of the following is associated with direct occipito-posterior or persistent occipito-posterior position. Again, a word play is going on here. So if they ask you OP position, your answer is android. Your answer is android. But if they ask you persistent or direct occipito-posterior position, your answer should be anthropoid. Anthropoid. And this anthropoid type of pelvis is associated with face to pubis delivery. It is associated with face to pubis delivery. So now you answer me, what is the type of pelvis which is associated with face presentation? With face presentation, which is the type of pelvis associated? Which is the type of pelvis commonly associated with face presentation? So this is one area very commonly where I see mistake from students. Face to pubis is anthropoid. Face presentation is something different. The face is directly presenting. Face presentation is with platypelloid. Is it clear? So these are the key terms. I want to stress the things where the mistake comes as well so that you don't make it in exams. Face presentation, platypelloid. Face to pubis is anthropoid. So you can just remember, if you want a small mnemonic, just remember FP. Anthropoid has AP, persistent OP, like a word play. Persistent OP, AP, FP, all can be linked together. Face to pubis, anthropoid, persistent OP presentation. All right. Okay. So coming to the next image, can you identify the conjugate or the diameter which is being measured in this image? What is the conjugate being measured in this image? So basically, they are trying to assess some anteroposterior diameter. This is anterior, this is the pubic symphysis, this is the sacral promontory. So basically, they are trying to assess some anteroposterior diameter at the level of inlet. So let's see the three diameters at the level of inlet. So you have a diameter which is connecting from the upper border of pubic symphysis till the sacral promontory. This is known as true conjugate, also known as anatomical conjugate. Next, you have from the most prominent part of the pubic symphysis or the mid part of the pubic symphysis to sacral promontory, that is the obstetric conjugate. Finally, from the lower border of sacral promontory till lower border of pubic symphysis till sacral promontory, you have the diagonal conjugate. Don't worry, it's already written. From the upper part till the pubic symphysis, the first one is the true conjugate or the anatomical conjugate. From the mid part of pubic symphysis till sacral promontory, you have the obstetric conjugate. From the lower part, the one which you have is diagonal conjugate. Now let's go back to the image, which is my hand measuring here from the lower border of pubic symphysis till sacral promontory. That is the diagonal conjugate. So, how to remember this? So, I just remember with the mnemonic, a toddler. Even I have a small toddler at my home as well. Just remember a toddler, a toddler. A and T are the upper ones. Next, you have the obstetric conjugate. Finally, the lower one is the diagonal conjugate, a toddler. You can use any mnemonic if you wish. But just to help you out, you can remember a toddler if you wish. All right. So among these conjugate, diagonal conjugate is the one which is clinically measured. Important question. Diagonal conjugate is approximately 12 centimeters. The obstetric conjugate is 1.5. It is nearly 1.5 to 2 centimeter less than the diagonal conjugate, and it is nearly 10 to 10.5 centimeter. So it is diagonal conjugate minus 1.5. Even some sources state it as 2 centimeter. Whereas this true conjugate is diagonal conjugate minus 1 centimeter. What is 12 minus 1? 11 centimeters. These are the various conjugates. Yes, very good. So I can see that everyone is thorough with this. So just remember a toddler. Anatomical, true conjugate are the topmost and upperwala ones. In the middle part, you have the obstetric conjugate, and niche you have the diagonal conjugate. True anatomical, obstetric, diagonal conjugate. The one with the maximum obstetric significance or the shortest one is obstetric conjugate, which is 10 to 10.5 centimeter. Okay. Now coming to the labor. So in labor, the main cardinal movements of labor include, just remember, ED fire, ED fire, ED fire. So you have engagement, descent, flexion, internal rotation, extension, restitution, external rotation. Just a summary of the various movements. So coming to the stages of labor. So in labor, the labor can be again divided as you have the first stage, second stage, third and the fourth stage. What is first stage? First stage is from the onset of cervical dilation till full dilation. So it is from the onset of cervical changes, cervical changes till full dilation. Whereas second stage is still the expulsion of fetus. In second stage, there is expulsion of fetus. In third stage, there is going to be expulsion of placenta. And in the fourth stage is nearly 1 to 2 hours after the delivery where you are going to monitor the patient. It is 1 to 2 hours post delivery where you will monitor the patient. All right. So a bit more about the stages. So again, these first stage can be divided as latent phase and active phase. In latent phase, again, the cutoffs are different. I have actually simplified all the numbers that you have to remember here. So the latent phase is different in primi-gravidas and multipara. So if it is a primi, in primi, the latent phase is nearly 20 hours. Multi, it is 14 hours. In case of primigravida, the normal rate at which in the active phase dilation happens is at the rate of 1.5 centimeter per hour, and multi it is just a change. In primi it is 1.2 centimeter per hour and multi it is 1.5 centimeter per hour. Remember that multi will progress more faster. So higher value will be in multi-parous woman. So 1.5 centimeter per hour in a multi-parous female. In a primi it is 1.2 centimeter per hour. And the minimum rate of progress is 1 centimeter per hour. In second stage of labor, so in second stage of labor, if you assess, again, you can easily remember with 2, 3, 4. 2, 3, 3 and 4. Just write 2 and 3. So in case of a multiparous female, the maximum duration of the second stage is 2 hours. In primipara, it is 3 hours. If the patient has an epidural, you just have to add +1. That is why I wrote 2, 3, 3 and 4. So here you will write 3 hours and 4 hours. 2, 3, 3 and 4. Just remember 2, 3, then 3 and 4. Third stage, usually what we do is active management of third stage of labor. I'll teach you the active management of third stage of labor. If we are practicing active management of third stage of labor, in that case, the placenta should be delivered within 30 minutes. Placenta should be delivered within 30 minutes. So the abnormalities that can happen during the labor include the latent phase can be prolonged. Just a minute. Yeah. So the latent phase can be prolonged and it is known as protracted latent. It is known as prolonged latent phase. Prolonged latent phase. In active phase, if the active phase is prolonged, instead of just calling it prolonged, we'll call it as protracted active phase. protracted active phase. In the second stage, there can be arrest of second stage of labor. A very commonly asked question is a patient is having prolonged latent phase. She is in labor in the latent phase for a prolonged duration of time. What are you going to do? Please don't do anything. Just wait, watch, and maximum you can give her some sedation so as to decrease the pain. This is a very frequently asked thing. Prolonged latent phase, she is just 1 centimeter, 2 centimeter, she has some pain. What are you going to do? Don't choose oxytocin, don't choose ARM. Just wait and watch for this patient. Okay, you are not going to do anything. You will wait, watch, and maximum you'll give her sedations. Are you thorough with that? Is it clear? Yes. All right. Okay. So, what is meant by term, preterm, and post-term? So, preterm, again, we can divide it as term is between 37 weeks till 42. Beyond 42, we'll call it as post-term. Less than 37 is preterm. Again, this less than 37 can be divided as early preterm, which is less than 34 weeks, and late preterm, which is between this 34 to 37 weeks, early and late preterm. So if a patient is in preterm labor, what are the things that you're going to give the patient? The most important is the steroid coverage. It is the steroid coverage. Steroid is basically for the lung maturity. And the drugs that we give include, we have the we have the dexamethasone and the betamethasone. We have dexamethasone and betamethasone, which is given as intramuscular injections. In the meantime, till the steroid coverage is completed, we need to relax the uterus. And for that, we give the patient tocolysis. And the drug of choice on tocolysis, the drug of choice, again a question, it is nifedipine. It is nifedipine. There are various drugs for tocolysis, but the most commonly used one or the drug of choice is nifedipine. And we give this steroid coverage only less than 34 weeks. Less than 34 weeks. Yes. Coming to the breach. So if there is an abnormality such as, just there's an image as well. This image-based question has come up last year. So what is the maneuver which is being performed? This is basically the Ridgen maneuver. So as to cause a controlled delivery of the head of the baby. So there is controlled extension of the head of the baby in which one hand is kept over the perineum, other hand is kept at the occiput of the head so as to cause a flexion of the head. The maneuver which is shown is a Ridgen maneuver. Next, coming to breech presentation. So in case of a breech presentation, the maneuvers that is used to deliver the baby, we basically go for an assisted breech vaginal delivery. So in assisted breech, basically I'm just going to not do much maneuvers. We'll just allow the baby to deliver spontaneously and we can assist in the delivery. So you have to know the names of these assisting which we do. So as to deliver the leg, what we do is Pinard's maneuver. In Pinard's maneuver, I'm going to give pressure on the popliteal fossa, P for P. Pressure on the popliteal fossa is given in the Pinard's maneuver. In case of Losset's maneuver, while we are doing a Losset's maneuver, it is basically to deliver the extended arms. So Losset is for arm and Pinard is for the leg of the baby. So next very important question which I was asked previously as well. All the following are used to deliver the head of the baby. So as to deliver the head, we can use three techniques. We have the Burn-Marshall technique, which is the first one which is shown. You have the Burn-Marshall technique. You have the MSV or Mauricio-Smellie-Wheat technique. And finally, you have the Piper's forceps. You have the Piper's forceps. MSV, Mauricio-Smellie-Wheat technique, Burn-Marshall method, and the Piper's forceps. These are the three techniques by which you can deliver the head of the baby. Yes. So, if a question is giving you that the baby is in transverse lie, in labor, if the baby In labor, if the baby is in transverse lie, in that situation, you have to go for a cesarean section. But again, I have posted this question yesterday only in my Instagram. There is a patient who has come at 36 weeks. She's not in labor. She has adequate, the baby weight is normal. How will you manage them? Most of the students have marked external cephalic version, which is basically right. And some had gone for cesarean section. So in the antenatal period, if the woman has come and you have a patient who is not in labor, the baby is adequately sized, the liquor is normal, you need not jump into cesarean section. You can basically go for an external cephalic version. So in the antenatal period, the management is ECV. If there is a neglected shoulder presentation, the patient has come and already the baby is dead, it was not diagnosed antenatally. In neglected shoulder presentation, already there is intrauterine death and the baby is in transverse lie. In that situation, again, your management is cesarean section only. Cesarean section. In case of a face presentation, if it is mento-anterior type, then you can go for a vaginal delivery. If it is mento-posterior type, you have to go for a cesarean section. This is how you will manage this scenario. Is it clear? Any comments? Till the external cephalic version, yes, cesarean section. Wrigley's and Piper's how to differentiate, I'll show you that. I'll show you the forceps part. All right, okay. Coming to active management of third stage of labor. Now coming to the labor part. So in active management of third stage of labor, basically it's again important. They will ask you about the steps of the active management of third stage of labor. So in this, the first thing that you give is the uterotonics. The uterotonics, the drug of choice is oxytocin. The first thing that you're going to give is oxytocin and it is 10 units intramuscular within 1 minute of delivery of baby. It is 10 unit oxytocin intramuscular. Oxytocin, among the uterotonics, oxytocin is the drug of choice. Next is you go for a delayed cord clamping and then controlled cord traction. So what is the image which is being showed here? Which is the image being shown here. This is basically controlled cord traction. I am not going to just pull out the cord. We will give a controlled traction to the cord only. This is a controlled cord traction. Along with that, we can wait for 1 to 3 minutes before clamping the cord. Again, in the postpartum period, I am going to be very vigilant and we will check for any evidence of atonicity, any evidence of bleeding. So we will continuously assess the tone. So can you point out what point has been removed from the active management of third stage of labor? Yes. Previously, the uterine massage was actually a normal part of active management. You had uterine massage. But currently, uterine massage is taken away. So you go for a uterine massage only if tone is decreased. So this usually comes as an all except question. All the following are steps of active management of third stage of labor except uterotonics, delayed cord clamping, as the uterine tone, uterine massage. Uterine massage was previously a part, but now not a part. Suppose there is another question. All the following are components except you have uterotonics, early cord clamping, assess the uterine tone, and uterine massage. Understand that early cord clamping is never done. Early cord clamping has never been a part of AMTSL. So early cord clamping is the worst answer, so as to come in all except question. So again, what is not a part? Never early cord clamping. Yes, early cord clamping is never a part of this. So, in the active management of third stage of labor, again, why do we do this active management? This is basically to prevent the postpartum hemorrhage, which is happening. So, the postpartum hemorrhage, what is postpartum hemorrhage? The expected bleeding that happens in a vaginal delivery is nearly 500 ml. In a cesarean section, it is 1000 ml. Any bleeding which is in excess of this, more than 500 ml in vaginal delivery, more than 1000 ml in cesarean section, or it is more than 1000 ml irrespective of the route of delivery, then we call it as postpartum hemorrhage. And if and another definition is that there is a fall in hematocrit by 10%. So more than 1000 ml irrespective of route of delivery, or there is a decrease in hematocrit by 10%. And among the various causes, the most common cause of PPH is atonicity. Most common causes atonicity. So again, the PPH, the causes can be, the types has been divided as primary and secondary PPH. Primary PPH is the bleeding which is happening within 24 hours of delivery, whereas secondary PPH, primary is within 24 hours, whereas secondary is between 24 hours till 12 weeks postpartum. That is 24 hours till 12 weeks postpartum. This is how you differentiate the primary PPH and secondary PPH. Within 24 hours primary, 24 hours till 12 weeks is secondary PPH. So as we discussed, even in active management, the first step was uterotonics. Even in PPH, the most important drug that you're going to give is, here also it's oxytocin. The first drug is oxytocin. The other drugs include, we have ergometrin, we have carboprost, misoprostol, and tranexamic acid. Tranexamic acid is an adjuvant. It is just an adjuvant. So how will you choose these drugs? Again, previously in the question, they had given that the patient has already received oxytocin, the bleeding is not controlled. Now the patient has hypertension. What is the drug that you're going to choose? The patient has hypertension. So understand that ergometrin is contraindicated in hypertension and cardiac disease. Hypertension and cardiac disease. Carboprostol is contraindicated in bronchial asthma. So look out for these contraindications. Once you see these contraindications, you will not choose these drugs. So question for PPH, we do early cord clamping or delayed cord clamping. In case of PPH, all right, usually the PPH, what happens is after the delivery of the placenta itself, we see it. So as such, PPH is not a direct indication for early or delayed cord clamping. No dear. Usually the dictum that we follow is active management of third stage of labor to prevent PPH. And in that active management, what we do is delayed cord clamping. It is delayed cord clamping. Yes, correct. So ergometrin causes continuous contraction. So ergometrin is basically, we don't give it in cardiac disease and hypertension. So the first drug or the drug of choice is oxytocin, followed by ergometrin, then carboprost. If the question is giving you that patient has bronchial asthma, you won't choose carboprost. If the patient has hypertension or cardiac disease, you won't choose ergometrin. All right. Next drug is misoprostol. Finally, tranexamic acid is just used as an adjuvant along with the treatment. So coming to a small topic, that is maternal mortality. One question that was asked is, what is maternal mortality? Maternal mortality is basically mortality that is happening either in the pregnancy or within 42 days of termination of pregnancy. So either it is within 6 weeks or during the pregnancy. So what are the causes? The most common cause of maternal mortality is basically our PPH. So what are direct causes and indirect causes? Direct cause means it is directly leading to the death of the baby. Most common direct cause is PPH, and most common indirect cause. Can someone comment the most common indirect cause? Let me check, is everyone sleeping or awake? What is the most common indirect cause? The most common indirect cause is anemia. Perfect. Very good. It is anemia. Again, this has been a question. The most common direct cause is PPH, and most common indirect cause among this is going to be anemia. All right. So this was an image-based question that came last year. This is basically showing you craniorachis. How do you identify? A main problem that students face was by looking at this image, they thought about anencephaly. But along with that, you see that the cranial vault is absent. They have this flat head. It is anencephaly is there. That is right. I agree with you. But along with that, there is a defect in the spine as well. There is no covering over the spine. This defect where there is problem at the level of crania, that is in the form of anencephaly, and there is no covering at the level of the spine, that is rachis. This is known as craniorachis. That is basically the correct answer here. This is craniorachis. Now let's discuss few basic things in pregnancy. That is the vaccination in pregnancy. So vaccination, what do we give? Is it TD or TT? As I always say, we give TD. TT is just what we say. We don't give TT, it is TD. So based on this info, they had given the question, how many doses of TD? I am going to give 2 doses of TD 4 weeks apart. 4 weeks apart. 2 doses of TD 4 weeks apart given as intramuscular injection. In case if the patient has received a dose or has received the complete immunization within the last 3 years, if completely immunized within 3 years, in that situation, you need not give both these TD again. You will just give her one booster dose of TD. You will just give one booster dose of TB. This was the question that came. So instead of directly giving you the patient was immunized within the last 3 years, they will give you that the patient already has a child of 2 years. That means most likely during that pregnancy, the patient might have received that vaccination. So in that situation, you will give just one booster dose of TB. Now there is the Tdap which is being advocated. Tdap basically has against pertussis as well, against acellular pertussis. It is given as an intramuscular injection and it is given at 26 to 28 weeks. It is a single dose. Single dose between 26 to 28 weeks, single dose as an intramuscular injection. That is the Tdap. All right. So let's come to some of the benign conditions in gynecology. First, let's discuss about endometriosis. Endometriosis has been repeatedly asked again. So endometriosis, basically the patient has a lot of pain. There is pain. So the patient has pain in the form of chronic pelvic pain. There can be dysmenorrhea, dyspareunia can be associated. Apart from this, the other common symptoms with the patient can have include infertility and adnexal mounts. This infertility and adnexal mounts. The examination findings include the patient. What will be the size of the uterus? The uterus is usually normal sized. Normal size uterus, but what is the problem? Due to the presence of the fibrosis and adhesions which are there, the mobility of the uterus is restricted. So there is restricted mobility. There can be a fixed retroverted uterus. Key point, please note this, fixed retroverted uterus is seen in. Fixed retroverted uterus is seen in case of endometriosis. Fixed retroverted uterus is a very commonly asked question. Once you see this point in the question, understand that they are talking about endometriosis. Another key point is nodularity. There is nodularity and tenderness in the pouch of Douglas over the uterosacrals. Nodularity and tenderness in the pouch of Douglas uterosacrals, you will think about endometriosis. Two key points which I want you to be thorough with. Fixed retroverted uterus, nodularity and tenderness in the pouch of Douglas and uterosacrals. What is the initial investigation that you are going to do? The first thing is ultrasound, so as to rule out other conditions. But the investigation of choice as such, the investigation of choice is laparoscopy. It is laparoscopy. where you look, you see, and even you can go for a histopathology to confirm it is indeed endometriosis. So the gold standard investigation is laparoscopy and histopathology. Gold standard is laparoscopy and histopathology. Investigation of choice is laparoscopy, but the best gold standard investigation is when you do a laparoscopy, take out a small biopsy from there and confirm it. So, laparoscopy and histopathological examination, HPE or histopathological examination. Diagnostic laparoscopy and histopathological examination is the gold standard in the diagnosis. So, what is basically an endometrioma? So this is basically showing you an endometrioma. So what is the typical appearance that you can see here? It has a ground glass appearance. It has a ground glass appearance. This endometrioma is also known as chocolate cyst. This is basically due to the endometriotic deposits in the ovaries. There is a cyst that is forming in the ovary. This is known as the endometrioma or chocolate cyst. So while we do the laparoscopy, once you rupture the cyst, you can see the chocolate colored fluid which is draining from it. This is the endometrioma or the chocolate cyst. Ultrasound feature is ground glass appearance. All right. So moving on. Next, coming to another pathology. If they show you this cross section, which has previously come for the NEET exam, the cross section of histopathological image of a uterus. This is basically an adenomyosis. What is the pathology in adenomyosis? There is presence of endometrial glands in the myometrium. So you can see these glands which are present in the myometrium and it has blood which is collecting inside it. This is basically our adenomyosis. So the uterus is enlarged. It is diffusely enlarged. It's not irregularly enlarged unlike a fibroid. Here it is diffusely enlarged uterus. It is globular. Can you appreciate the globular round like uterus? Diffusely enlarged, it is globular. It is globular. And usually in this situation, the size of the uterus is less than 14 weeks. What is the investigation of choice and the gold standard investigation? So initially we try to diagnose it with ultrasound, but always ultrasound need not be conclusive. Once the ultrasound is inconclusive, in such situation, we go for MRI. MRI, when USG is inconclusive. When USG is inconclusive, we go for MRI. And the gold standard investigation is basically shown here. I take out the uterus, look for the histopathology. The gold standard investigation is basically HPE, histopathological examination. So investigation of choice is MRI if ultrasound is inconclusive, and the gold standard is histopathological examination. Is it clear? Any questions? Yes, symmetrically enlarged. Yes, very good. Correct. All of you have correctly answered. Yes. Now, coming to a very, very important topic, how to differentiate between the various vaginal discharges. So this is a very simple box actually, but so many questions. Maybe because we see a lot of vaginal discharge in OPD as well. It's a very common scenario. So they want you to be thorough how to differentiate these different vaginal discharges, that is C. So coming to the discharge one by one. In candidiasis, the discharge is curdy white. Curdy white. In trichomonas vaginalis, you see a green frothy discharge. In bacterial vaginosis, there is a thin gray-white discharge. Thin gray-white discharge. In candidiasis as well as in trichomonas vaginalis, there can be presence of itching. The normal vaginal pH is acidic. This vaginal acidic pH is maintained in case of candidiasis. So in candidiasis, usually the pH is between 3.5 to 4.5. That is the normal vaginal pH is maintained. So what is the pH in case of bacterial vaginosis and trichomonas vaginalis? It slightly shift towards the more alkaline side. It is more than 4.5. It is more than 4.5. The characteristic feature in Trichomonas vaginalis, you see a strawberry cervix and vagina. There can be strawberry cervix is seen in Trichomonas vaginalis. In case of bacterial vaginosis, some characteristic features include fishy odor. There can be fishy odor, positive whiff test, positive whiff test. These are some of the associated features. The investigation of choice is basically I'm going to take this discharge, put it in a slide, do a wet mount microscopy. So the investigation of choice is wet mount microscopy. What is the management? So can you comment the drug of choice, the main treatment that is given for bacterial vaginosis and trichomonas vaginalis? What is the drug of choice that you give? What is the drug of choice in bacteria? Very good. It is metronidazole. I'm basically going to treat with metronidazole. Whereas in case of candidiasis, the treatment is fluconazole. It is fluconazole. Yes. Someone has very rightly mentioned about clue cells. So that's in the next image. What is the cells that is shown here? This is basically the clue cells. So clue cells are basically the vaginal epithelial cells which is studded with the bacteria. As you see in this image, these are the vaginal epithelial cells which are studded with the bacteria. These are the clue cells which can be seen in this image. So where do you see the clue cells? It is seen in bacterial vaginosis. Coming to a very important topic which has been repeatedly asked multiple times is our carcinoma cervix. So in carcinoma cervix, the main thing that you have to understand is about the management of carcinoma cervix. So before going to the management proper, let's first discuss about the most important risk factor which is associated. As you can see in this image, it's full of the previous year questions. And often I get questions from students as well how to learn this carcinoma cervix very easily. So carcinoma cervix, the most important risk factor is basically our HPV, human papilloma virus. And which are the high risk strains? The maximum risk is with 16 and 18. 16 and 18. The vaccines that are available include, you have the Cervarix, Gardasil, and the Gardasil 9. Cervarix, Gardasil, and Gardasil 9. Cervarix is a bivalent vaccine. Gardasil is a quadrivalent vaccine. And Gardasil 9 is a nonavalent vaccine. So now let's discuss briefly the management of carcinoma cervix. So are you all with me? Yes, management options. So basically, it's very simple. The management of carcinoma cervix, you have just two options. You have the option of surgery, you have the option of radiotherapy. So surgery is done. The main principle is that I will go for a surgery only if the size of the lesion is less than 4 centimeter. If it is less than 4 centimeter only, I can go for a surgery. If the size is beyond 4 centimeter, I will only go for radiotherapy. So which are the stages in which I can go for a surgery? The stages include patients who are in stage 1A, 1B1, 1B2. Is 1B3 included? No. So I want you to write a big 1B3 and cut over it. 1A, 1B1, 1B2, and 2A1. These are the stages where you will go for surgery. Anything apart from this, your management is radiotherapy. That means in 1B3, 2A2 till 4, your management is radiotherapy. Is it clear? This is how you manage. If the size is less than 4 centimeter in 1A, 1B1, 1B2, as well as in 2A1 surgery, anything apart from this, you will go for radiotherapy. All right. So in radiotherapy itself, it's not the plain radiotherapy that we give. The radiotherapy that is given is CCRT. What is the CCRT? CCRT is concurrent chemo radiation. So radiotherapy is the main management, but along with that, I'm going to add some chemotherapy as well. So if the option is giving you one as radiotherapy, one as chemo radiation, again, they have asked you this previously. Which will you choose? The best one is concurrent chemo radiation. Again, next question. So this is one question. This is the next question. So the ideal one is concurrent chemo radiation. Next question. So I told you I'm going to give the patient concurrent chemo radiotherapy. What is the chemotherapeutic agent which is most commonly used? What is the chemotherapeutic agent? So the chemo that you give, the chemotherapeutic agent that you give most commonly is cisplatin. Cisplatin. So many questions right from this one single slide. Is it clear for you? Very important point. Very important slide actually. So surgery is basically done when the size is less than 4 centimeter in 1A1, 1A2, 1B1, 1B2, but not in 1B3. Also in 2A1. When do you do radiotherapy? 1B3, 2A2 till 4, we are going to go for radiotherapy. And it's not plain radiotherapy, it is concurrent chemo radiation. We give chemo along with radiation because this chemotherapy will act as a radiosensitizer. And the chemotherapeutic agent is cisplatin. Very important concept. So many questions have been repeated. That is why I am again repeating it once again. Hope this is perfectly clear now. All right. So coming to some things about ovarian tumors. So in the ovarian tumor, again, if you get a question on ovarian tumors, I want you to divide it as whether it is in the postmenopausal or in the reproductive age groups. In the reproductive age groups, again, we divide the size, we divide the cyst depending upon the size, whether it is less than 5 centimeter, 5 to 7 centimeter, or beyond 7 centimeter. In less than 5 centimeter, we did not do anything in a reproductive age group female. If it is between 5 to 7 centimeter, I'm going to follow up these patients. We'll follow up with serial imaging. And usually we go for ultrasound for the initial assessment. More than 7 centimeter is the time where we either go for a surgical removal, or the other option is at least you have to do an MRI evaluation. MRI evaluation. So more than 7 centimeter surgical removal or at least MRI evaluation has to be done in these patients. This is how you are going to evaluate the patient with ovarian tumor. So suppose that the patient is postmenopausal. In postmenopausal, I want you to look at the CA125 as well as there is something known as risk of malignancy index. So CA125 in a postmenopausal female levels more than 35, or RMI, that is risk of malignancy index, which is more than 200. In these scenarios, there should be high suspicion of malignancy. There is high suspicion of malignancy and you have to manage accordingly. You have to manage accordingly. A very commonly asked cyst, what is the cyst which is being shown here? This is basically our dermoid cyst. This is our dermoid cyst. So this dermoid cyst basically has components from the ectoderm, endoderm, and mesoderm. So if you see a cyst, which basically has this hair, some yellow sebaceous material, some white cartilage such as bone or some cartilage part. Think about dermoid cyst. Some of the important one-liners from dermoid cyst include it's the most common GCT. It is the most common GCT is germ cell tumor. It's the most common ovarian tumor in the reproductive age group as well as in pregnancy. It is the most common ovarian tumor to undergo torsion as well. So you can easily remember it with the mnemonic TRAP. TRAP, TRAP. So T stands for torsion. T stands for the torsion. RA is for reproductive age group and P is for pregnancy. So this is the most common ovarian tumor to undergo torsion. This is the most common ovarian tumor in the reproductive age group, and this is the most common ovarian tumor in pregnancy. So you can easily remember with the mnemonic TRAP, torsion, reproductive age group, and in pregnancy. So next, let's discuss about some contraceptive methods which is commonly asked. So in the contraception, we have intrauterine devices. So can you tell me what is the intrauterine devices which is being shown in these images? Can you comment upon the intrauterine devices which has been shown here? Anyone? The first image is basically, let me give you a clue by which you will only come to the diagnosis. It has a T. The answer itself has a T in the name because this looks like a T. So the device also has a T. That is how you identify, all right. The answer is right there in front of you itself. It's a T, so the answer has T in it. It is copper T380. It is copper T380. The key features include, you will see the copper which is there in the horizontal limb as well as in the vertical limb. Whereas the next device which you see here is multi-load. It is multi-load and it is 375. Multi-load 375 and copper T 380A. Yes. And the half-life or the how long, what is the lifespan of this intrauterine device? For copper T 380A, it is 10 years. It is 10 years. Whereas multi-load, it is 5 years. It is 10 years and 5 years. So these are basically second generation intrauterine devices. The first generation intrauterine devices included Lippy's loop and all. They are inert devices and they are not being used now. Next, you have the second generation. Finally, you have the third generation devices. This includes the hormone containing or the LNG containing devices. And a very important example is our Mirena. Yeah, third generation intrauterine devices. So again, this has come as a spotter as well. The 380A, the T where you see one in the horizontal as well as vertical arm, this is copper T380. And when you see there is copper, which is only there in the vertical arm, the horizontal arms are bent and there are small projections like burrs over it. This is how you identify the multi-load which is there. All right. So there can't be any exam where they don't ask about emergency contraception. Emergency contraception is also very important. So what are the common drugs that is used for emergency contraception? What is the most commonly used emergency contraception? That is basically our I pill or the levonorgestrel containing tablets. So the most commonly used is this one. Most commonly used is levonorgestrel containing tablet, and the most commonly given dose is we give 1.5 milligram as a single dose. And this has to be given within 72 hours of unprotected intercourse. Within 72 hours of unprotected sexual intercourse, this has to be given. Just give me a second. So section has been going on for some time. The charge is dying out. Yes, set to go. All right. So the most commonly used one is the LNG containing, and it is basically the I pill which commonly comes. The dose is 1.5 milligram single dose, which is given within 72 hours. Or it can be given in divided dose as well. You can give 0.75 milligram. You can give an initial dose and again repeat it after a period of 12 hours. You will give next dose 0.75 milligram. This has to be given within 72 hours. Other options include you have copper containing intrauterine devices, you have the OC pills which can be given. Usually we give multiple doses. If it is high dose pills, we give two high dose pills. Again, repeat after 12 hours, again, two high dose OC pills. If it is a low dose pill, we give four low dose pill. After 12 hours, we again repeat four low dose pills. So I want you to understand these names for an all except question as well. What are the different types of emergency contraception? They can give you an all except question. Levonorgestrel can be used. Copper containing intrauterine devices can be used. 11. It is a ulipristal acetate can be used, and there is sencromen. This ulipristal acetate is usually given as a single dose. We give as 30 milligram single dose, and it can be given within 120 hours of sexual intercourse, within 120 hours. Copper T was initially given till 5 days or 120 hours. Now they are stating that it can be given up till maximum 7 days. So copper T should be inserted ideally within 5 days or 120 hours. But maximum effect or the effect can be observed maximum till 7 days. So again, let me explain this. What are the various drugs that can be used? This can come as an all except question. Please have a note of the various drugs. The most commonly used one is levonorgestrel containing, which is our I pill, 1.5 milligram single dose within 72 hours of unprotected sexual intercourse. All of you know that. Or you can divide it and give 0.75 after 12 hours. Again, repeat another dose. The other drugs, at least you should know the names of the other drugs. You can use pills. High dose pills means give 2 tablets each. Low dose pills means give 4 tablets each. You can use copper intrauterine device up till 5 days, maximum till 7 days. Ideally, within 5 days of unprotected sexual intercourse, this has to be inserted. Ulipristal acetate, single dose, 30 milligram within 120 hours. Finally, another drug is sencromen. This is not very commonly used as emergency contraception, but even sencromen, which is a selective estrogen receptor modulator. So it can be used for emergency contraception. So please note the important commonly asked questions from this as well. They ask you all except question from this, the doses of the levonorgestrel that has to be known. Till what time can you give this LNG containing pill? Till what time can you give the ulipristal? That is till 120 hours. Copper T ideally within 120 hours, maximum till 7 days. I'm again repeatedly revising this again because emergency contraception is an important topic. Only TT. Only TT, we give TD actually. It is, yes, we give TD actually rather than TT. It is TD, 1.5 milligram LNG. That is correct. Yes. Sencromen is also known as Chaya. That is true. Sencromen is also known as Chaya. All right. Okay. CA cervix management, yes. So CA cervix management, I can just briefly discuss once again if you want. CA cervix management, basically, we divide it as we have two options. We have the option of radiotherapy, we have the option of surgery. We do the surgery if the size of the tumor is less than 4 centimeter. I'm just recapping the same thing. We do the surgery if the size of the tumor is less than 4 centimeter. The surgery is basically done in stages 1A1, 1A2, 1B1, 1B2, not in 1B3, also in 2A1. So what are the places where you go for surgery? 1A, which includes 1A1, 1A2, 1B1, 1B2, and 2A1. In all others, I'm going to go for radiotherapy. In radiotherapy, the preferred treatment is concurrent chemoradiation. It is concurrent chemoradiation. And the chemotherapeutic agent which is given is cisplatin. Is it clear? This cisplatin. It is cisplatin, yes. Coming to a small topic, which is menopause. So, if a patient is having menopause, it's well and good if you learn about staging as well. Yes, if you want, we can discuss. It's well and good if you understand what is meant by each of these stage as well. But it's not possible to cover each and everything in rapid revision. But if you want to know the staging, we can quickly go through that as well. Yes, first let's finish with this. Then, if you want the staging, you can. Yes, staging is not that difficult in case of CS cervix, but it's well and good if you know the CSS staging as well. Yes. So, coming to the next part about the menopause. So, in menopause, the main treatment that you give is hormone replacement therapy is the main treatment. So, even in any case, first thing is we try to manage it conservatively. So, you have lifestyle management, but that is not often asked. They will ask you about the drugs, which was asked in July 2023 as well. So, the main management in the drugs is hormone replacement therapy. So, for a patient who has undergone menopause, what is the hormone that is deficient? It is basically estrogen. They have low levels of estrogen. They have low levels of estrogen. So, I am going to replace this estrogen for the patient. So, this can be given as either estrogen alone or estrogen plus progesterone. So, a common question is for whom will you give estrogen alone? For whom will you give estrogen plus progesterone? The thing you have to understand is if I just give the patient estrogen, if I keep on giving estrogen, there will be thickening of the endometrium. This is known as endometrial hyperplasia. There can be thickening of the endometrium under the influence of estrogen, and this can lead to endometrial hyperplasia and even endometrial cancer. Endometrial hyperplasia and endometrial cancer as well. So as to negotiate this effect of endometrial hyperplasia and cancer, we will add progesterone to stabilize the endometrium. So ideally, whenever we talk about HRT, I'm going to give estrogen plus progesterone. HRT usually includes estrogen and progesterone. So why do I add progesterone? So as to stabilize the endometrium. So if a patient has her uterus already removed, does she require any progesterone to stabilize the endometrium? No, there is no role of progesterone now. So if already hysterectomy has been done, you can just give her estrogen. No need of progesterone. This is the basic concept. If the patient has uterus, you will give her estrogen plus progesterone. If the patient has a hysterectomy done, you will give her just estrogen for the patient. Suppose the last question which was asked is if there is a postmenopausal female who has vulval itching, there is vulval atrophy. Vulval atrophy means basically due to the low level of estrogen, the vulval epithelium has undergone atrophy and the patient can have itching, discomfort, vaginal dryness could be there. So in such a situation, what is the treatment that you're going to give? For these genitourinary local symptoms, you can just give her estrogen cream. So in such situation, you will give her estrogen cream for management. You need not give her estrogen plus progesterone. You can just give her estrogen cream. So is the management clear? If the patient has uterus, you will give her estrogen and progesterone. If the patient does not have uterus, you just give her estrogen so as to negotiate these menopausal symptoms. If the patient has vulval atrophy, vulval itching, they can give you vaginal dryness. There is vaginal dryness. All these local symptoms. In this local symptoms, you can just give her local application of estrogen in the form of estrogen creams. There you need not add progesterone. This is basically how you manage a menopausal patient. Okay, coming to VVF. Actually, in VVF, there has been multiple questions and VVF. Let's see some of the important things from VVF. In VVF, you should know about this methylene blue dye test. So, methylene blue dye test is also known as the three swab test. So, in this, we basically fill the bladder with this methylene blue dye. So, I have already filled this bladder with methylene blue dye for you. So, we fill the bladder with methylene blue dye and we insert three swabs in the vagina and we look which swab is stained and soaked so as to assess for the site of the fistula. So the common fistulas include, you have the most common one is vesico-vaginal fistula. So can you appreciate this fistula which is between this bladder and the vagina? Between the bladder and the vagina. This is our VVF or vesico-vaginal fistula. This is our VVF or vesico-vaginal fistula. This has been a question as such, an image-based question. So it's actually direct and simple. You just see which parts are being connected. You have the vagina, you have the bladder. Vesico means basically bladder. It is a vesico-vaginal fistula. Another point is vesico-vaginal fistula is the most common fistula. Among all the different types of fistulas which I'll discuss now, among these, the most common is vesico-vaginal fistula. So you have vesico-vaginal fistula. The other types include, they can be fistula between the urethra and the vagina. This is the urethro-vaginal fistula. You have the urethro-vaginal fistula, the vesico-vaginal fistula, and next, there can be connection between the ureter and the vagina, urethro-vaginal fistula. Urethro-vaginal fistula. So, yes, urethro-vaginal fistula. So, how do you differentiate between these three? Already the names are given here for you. So these three fistulas can be differentiated by using our three swab test. So let me give you the key points that are going to help you to differentiate this. Again, this has been asked. So if it is a urethro-vaginal fistula, so where is the connection? Please have a look here. It is between the urethra and the vagina. So once the dye is filled, this is going to basically go and soak the lower swab. So the lower swab is soaked and stained in case of urethro-vaginal fistula. So which swab is soaked and stained? Urethro-vaginal, it is the lower swab. Lower swab is soaked as well as stained. All right. In the next one, let's go to the topmost one, urethro-vaginal fistula. So the connection is between ureter and the vagina. So if I inject a dye into the bladder, this dye is going to only fill up the bladder. It won't fill up the ureter as such. So from the ureter, if there is fluid which is coming here, so suppose this is the urine which is there, and this urine is going into this swab which is there. So the swab will be soaked but not stained. So what is happening here? Upper swab is soaked but it is not stained. Finally, coming to the vesico-vaginal fistula. When there is vesico-vaginal fistula, characteristically they say that it is the middle swab. So let me draw it like that here for you. It is usually the middle swab, but it is not always the dictum. Suppose the patient lies down, even the upper swab can be soaked. Once the patient is walking, due to gravity, even the lower swabs would be soaked. But typically they give you in the question as middle swab. Middle swab is soaked and stained. Middle swab is soaked as well as stained. So in this scenario, you will think about the vesico-vaginal fistula. So even the upper can be soaked, even the lower can be soaked. So what are the key findings? It's very easy to differentiate uretro and Urethrovaginal as well. Ureterovaginal, soaked, not stained. Urethro, it is the lower one which is soaked and stained. VVF, usually the middle swabs are soaked and stained, but even the lower and even the upper swab could be also soaked and stained. So you understand that this is not a definitive test, right? This is not the best test or not a test which we even perform commonly in OPD as well. The investigation of choice for a vesicovaginal fistula is actually our cystoscopy. It is cystoscopy. In cystoscopy, basically, I'm going to insert a camera into the bladder and we will check for the size of the fistula, site of the fistula, number of fistula, all these are checked. So the investigation of choice is cystoscopy. Cystoscopy. And the VVF, the management, the treatment of VVF repair is also important. The treatment is basically I'm going to go for a surgical repair. Surgical repair. There are methods such as Latsko surgery, and they ask you about the timing of repair. So the VVF can be due to various causes. Mostly in developing countries such as in India, it is due to obstructed labor, which is an obstetric cause. If it is due to an obstructed labor, usually there is a lot of edema which is there. So I don't repair it immediately. We have to wait at least the minimum time which we will wait. Minimum we will wait for 6 weeks. An ideal time to repair it is after 3 months. Ideal time is after 3 months. If it is due to a surgery, that is in developed countries. So as I told you, in developing countries, this is due to usually due to obstruction. Whereas in developed countries, this is usually associated with surgery. And if it is diagnosed within 24 hours, so I have done a surgery within 24 hours, we have diagnosed this fistula. We will repair it immediately. Don't wait for any time. But beyond this 24 hours, what happens is there will be a lot of edema that comes and settles in. So due to this edema, again, there will be chance that if I do a surgery, there can be failure of the surgery. So if I diagnose within 24 hours, repair immediately. Within 24 hours, immediately. And beyond 24 hours, there will be a lot of edema. That's why we have to wait for minimum. Again, here we'll wait minimum for 6 weeks. So that there are just two values which you have to remember. 6 weeks and immediately. Immediately, if we diagnose in a surgery, within 24 hours, do the surgery immediately and repair it. After a surgery, if it is diagnosed after 24 hours, you will wait for 6 weeks. If it is an obstruction, such as an obstetric cause, there will be a lot of edema. Again, minimum wait for 6 weeks. Ideal is beyond 3 months. You can find all these questions. Is it clear? Is it clear? 6 weeks, yes. No stain in ureter. Very good. No stain. When it is a ureterovaginal fistula, there won't be any stain because the dye is not going there. No stain. Yes. Most common is VVF. You're all absolutely right. Yes, Nihal. Topical one in case of menopause, the topical we have local symptoms alone. We will be giving topical estrogen creams. Okay, one question from Dr. Aspiring is vaginal discharge according to normal physiology at what time? Yes. So what happens is just prior to the date of ovulation and all, we have estrogen as the predominant hormone. Once the ovulation happens, corpus luteum will produce the progesterone. Yes. So under the effect of these estrogen, the cervical mucus is very thin, it is stretchable, there is a lot of water content in it, there is a lot of salt content in it. So that is the time under the influence of estrogen, you see this thin cervical mucus. So prior to the date of ovulation, you can have some discharge which is present, which is due to the effect of the estrogen which is there. So when do we see the maximum physiological discharge? Even when OPD patients come with discharge, I usually ask them the time. Prior to the time of ovulation, they can have this profuse vaginal discharge. Now, not very profuse, but still, they can have some amount of vaginal discharge, which is under the effect of estrogen. So this happens prior to the date of ovulation. Usually in the question they give you on the 12th day there is discharge. On the 11th, 12th day the patient has come with discharge. So how to differentiate from the other discharges? So in case this is a normal discharge, so the pH is maintained. The pH is acidic only. It will be between 3.5 to 4.5. It is a normal discharge. So the patient should not have any abnormal findings. Normal discharge means there won't be any itching, there won't be any foul smell, there won't be any change in color. So remember that it is normal, no abnormality, no foul smell, no itching, no change in color as such, or no change in pH. Everything is normal. Even the lactobacilli would be present, and it would be normally the vagina has lactobacilli. It can be present along with the discharge. This is how what are the key features of a normal vaginal discharge. All right. Yes, I hope that question is clear, aspiring doctor. Yes. All right. So, coming to a very important topic, that is Asian man syndrome. So many questions, right, from Asian man syndrome. So, what is Asian man syndrome? Asian man syndrome is basically a uterine synecdoche. There is adhesion between the uterine walls. There is adhesion between the uterine walls. Why does this happen? Asherman syndrome, the most common cause is curettage, where we do this dilation and curettage. So much curettage is done. Excessive curettage can lead to the injury to the endometrium, and even there can be adhesions between the endometrial walls. So the most common cause is curettage. And the most maximum time, the maximum risk period time is basically in the postpartum period. It is in the postpartum more than post-abortal. So if I am doing a curettage for a patient who is in the postpartum period, that's after delivery, suppose she has some retained products and I do this curettage, this is the time which has the maximum risk. What are the symptoms that is associated? The symptoms include hypomenorrhea and even amenorrhea. Hypomenorrhea and amenorrhea. What is the investigation of choice? The investigation of choice is right there staring at you. So what do you see here? Here you can see the uterus and you can see some filling defect. What is the characteristic of the filling defect? It is irregular. Irregular filling defects are seen in HSG. So in HSG, you will see irregular filling defect. Irregular filling defect. What is the gold standard investigation? The gold standard is basically hysteroscopy. While I do a hysteroscopy, I can cut out these adhesions as well. I can remove these adhesions and I can diagnose it at the same setting. So I can diagnose and even treat it in the same setting. So the gold standard is hysteroscopy. Hysteroscopy, and the management is hysteroscopic adhesiolysis. Along with hysteroscopy, I'll cut out these adhesions. Hysteroscopic adhesiolysis is the gold standard in the management. So as we are discussing about HSG, let me show you a normal image of HSG as well. This is showing a normal HSG where you can see the small tubes, the fimbria, and some form of spillage. Ideally, there should be spill from both the sides, the tube and the spill from both the sides. Whereas in the next image, if you see, have a look at this image, what do you see there? Please comment, what do you see in this image? What do you see in the next image which is there? No answers? Yes, you can see that there are dilated tubes which is present. So this is basically due to a distal block. This can be due to a fimbrial block or a distal block, which can lead to collection of fluid within the fallopian tube and lead to condition such as hydrosalpinx. This is basically a distal block or a fimbrial block. Whereas in the next image, if you see, you will see that there is just one horn of the uterus. Can you appreciate only one side you can see, and there is a tube which is there and some spillage. This is basically showing you a uniconvate uterus. Uniconvate uterus is the uniconvate uterus. So fimbrial block, distal block is seen here, and a common cause of fimbrial block or distal block is our pelvic inflammatory disease. Pelvic inflammatory disease is a cause of fimbrial block or distal block of the tubes. So again, a common question which I get from students, how to differentiate between septate and bicornuate uterus. So let me tell you an easy way to differentiate between these two. So if you look at these, the cavity, which is basically seen like this in both these, you can see the two horns which are there. So in case of septate, they are closer together, whereas in biconvate, they are so farther apart. They are further apart actually. So the interconval distance, that is the distance between these conva, let me mark it up for you. Distance between these conva, the interconval distance is less. They are nearer in case of a septate uterus. The interconval distance is less than 4 centimeter in septate, whereas interconval distance is more than 4 centimeter in biconvate. Just remember this, closer, farther apart. Closer septate, biconvate is further apart. Next is angle. They are more closer means the angle is acute. So if you have a look at this angle, it is acute. It is acute. Whereas here they are further apart. The angle is obtuse. So let me be frank with you, even radiologists finds it difficult sometimes to differentiate between septate and bicornuate. It's not always very clear, but once they give you an image-based question, it is going to be pretty clear. They won't give you a confusion. The image has a lot of confusion. You will be able to differentiate by these features. Just look at the angle and the distance between them. They are further apart. The angle seems obtuse. Think about bicornuate. If it is closer and the angle is acute with the interconval distance less than 4 centimeter, you will think about septate uterus. So this is not the best investigation. HSG is not the best actually, because even there can be confusion even for the radiologist. But believe me, once they give you that image, it will be a very clear-cut image. Like this is actually a very clear-cut image in which you see it very farther apart and closer in case of a septate uterus. So is it clear how you differentiate the? Yes, banana uterus is also, the uniconvate is also known as banana uterus. It looks like a banana. Yes, you are right. Aspiring doctor, yes. Uniconvate can also be called as banana uterus. Banana uterus. Absolutely right. All right. Now, a key important table, how to differentiate between AIS and MRKH, androgen insensitivity and Muller-Rokitansky-Kuster-Hauser syndrome. You don't need the full form actually. Just remember MRKH, that's fine. So, AIS, basically, it is a karyotypically a male. So, the karyotype is 46XY. 46XY. So karyotypic male with a phenotype of a female. So the karyotype is 46XY, but the external phenotype is that of a female. So what would be the gonad? They basically have a Y. As Y chromosome is present, the gonads are going to be testis. It is testis. The gonads are testis. In the internal genitalia, in androgen insensitive syndrome, they don't have a uterus. The uterus is absent. They don't have a fallopian tube. But external genitalia is that of a female. As the name suggests, it is androgen insensitivity syndrome. The body is insensitive to androgen. That is why the internal Wolffian duct does not develop properly. As they are insensitive to androgen, you know that the hair development requires androgen. These individuals are insensitive to androgen, so they don't have any hair. They don't have pubic hair. They don't have axillary hair. What about breast development? All these excess androgens are converted into estrogen. So they have high levels of estrogen, and this estrogen will lead to well developed breast. They have well developed breast. So for breast development and this pubic hair axillary hair growth, we have something known as Tanner staging. This Tanner 4 and 5 are actually well developed. So instead of directly giving you well developed breast, they will give you Tanner stage 4 or Tanner stage 5 breast development is present. Associated with this, associated with androgen insensitivity syndrome, these testes can develop some malignant transformation. So they are at risk of gonadoblastoma. They are at risk of gonadoblastoma. That is why we have to remove these dysgenetic gonads. So what has to be done? We have to do a gonadectomy. When is this gonadectomy done? Gonadectomy is done at the time of puberty, after the secondary sexual characters are completed. Why is it so? These gonad produce hormones which is required for the secondary sexual development. So I want those changes to be completed. After that period of time, we can go for a gonadectomy. So gonadectomy is performed after the development of puberty. After puberty, that is after the secondary sexual characters are completed. The development of the secondary sexual characters are completed. After all the secondary sexual characters are completely developed, then we go for gonadectomy. Now coming to MRKH. So MRKH is basically a female. She is karyotypically also a female, phenotypically also female. Only problem is the Mullerian duct is not developing. The Mullerian duct leads to the development of the uterus, fallopian tube, and the upper vagina. So these females, they are basically 46XX. So they have ovary. Only problem is, as the Mullerian ducts are not developing properly, they won't have a uterus. The uterus is absent. The fallopian tube may be absent. The upper vagina is absent. So as I discussed, the uterus, fallopian tube, and the upper vagina develops from the Mullerian duct. They are basically, as we discussed, normal female itself. So the breast development is normal. Pubic hair development is normal. The external genitalia is normal. All these are normal to that of a female. All these are normal for a female. Normal female external genitalia, normal female breast development, normal pubic hair as like a female. But they can have some associations. They can have abnormalities of the spine. Abnormalities of spine and kidney development. Some associations in the kidney include they can be renal agenesis, development of one kidney might not have happened properly. There can be problems in the spine, such as there could be hemivertebrae. Only one side of the vertebrae is developed, other side is not developed. Just remember, they can have spine and kidney abnormality. What is the treatment? So in these individuals, they don't have uterus, they don't have upper vagina, they don't have the fallopian tube as well. Only the lower part of vagina is there, due to which they can have problems in the intercourse. So we can do a surgery so as to increase the length and size of vagina so that they can have normal intercourse. So the management is vaginoplasty. Vaginoplasty is the management. Even in case of AIS, along with gonadoplasty, we can also do a vaginoplasty for them as well for normal intercourse and the sexual function to happen. This MRKH, basically they have ovary. They have this ovary. Due to the presence of this ovary, they can have their own children. Using a surrogate, they can take their own egg and go for a surrogate for pregnancy. Is it clear how you differentiate this AIS and MRKH? These are the key differentiating factors between AIS and MRKH. Next, coming to imperforate hymen, an ever favorite. So imperforate hymen, again, a very Important image-based question, clinical question, all of this. So again, imperforate hymen, the patient will have primary amenorrhea. The patient will not have had her periods. So basically, they are bleeding from inside, but the blood is not coming outside. So this is known as cryptomenorrhea. The blood is hidden somewhere. It is cryptomenorrhea, also known as cryptomenorrhea. Cryptomenorrhea. So in this, the clinical features include the patient can have primary amenorrhea. The patient can have cyclical abdominal pain because in each periods, she has this blood which is collected inside. So due to which she can have cyclical abdominal pain. This blood will also be collected in the uterus. So while you do a per abdominal examination, you can feel that the size of the uterus is increased. You can feel a suprapubic bulge. So there can be suprapubic bulge. When you do a local examination, very important key point, on local examination, you will see a bulging bluish membrane. Can you appreciate it here? The bulging bluish membrane. Very, very important. Bulging bluish membrane which increases in size on coughing, straining, valsalva is denotive of an imperforate hymen. Bulging bluish membrane. There is a bulging bluish membrane which increases in size on coughing, straining, as well as Valsalva technique. This is the imperforate hymen. So again, in the clinical scenario, image-based question, this is very important. So what will be the management? This is basically the hymen which has not imperforated, which is blocking the blood from coming out. So I can put an incision so as to drain out these blood. So what is the incision that I put? It's a cross-shaped incision. This incision is known as cruciate incision. The management is simply put a cross there. Cruciate incision. The management is cruciate incision is applied for imperforate hymen. Yes. Now already the answer is given there along with the question, but again this is a very important image-based question. When you see a bulge in the posterolateral part of vagina, posterolateral part, again I had posted this question today in the PYQ series in my Insta as well. So what is the image that is shown? This is basically Bartholin cyst, a swelling which is present in the posterolateral wall of vagina. Posterolateral wall of vagina. This is the Bartholin cyst. So you have a small Bartholin's gland which is there, which is present at the junction of anterior 2/3 and posterior 1/3. And this Bartholin gland has a duct which drains. So if I draw a perineum here, this Bartholin's gland is present here which drains in between, it opens in between the labia minora and the hymen. The Bartholin's duct opened in between the labia minora and the hymen. Labia, this is the labia minora, you have the vaginal orifice, which basically has the hymen. Between the labia minora and this, the hymen, this Bartholin ducts drains. Whenever there is obstruction of these Bartholin's duct, due to some cause it is obstructed, what will happen? There can be Bartholin cyst. So what is the cause of Bartholin cyst? It is due to obstruction of the Bartholin's duct. Finally, what can happen? In this cyst, there can be some infections which will lead to Bartholin's abscess. So further on, it can lead to abscess of the Bartholin's abscess. And the most common organism which is implicated is E. coli, followed by gonococci. Many of you have a confusion that is gonococci, which is most common. It's actually E. coli, followed by gonococci. Most common is E. coli, followed by gonococci. Is it clear? This is about Bartholin's cyst. Very important image-based question. Yes. Okay, Discarded has asked how long will the class continue? It's about to come to an end, don't worry. NEET PG questions, both option unicornate and bicornate. Yes, dear, they can give you unicornate, bicornate. Both will be there in the options. I'm not saying you that only unicornate. You can, they will give you options like there will be unicornate, bicornate, septate uterus. All these options will be there. But I told you how to differentiate between this. In unicornate, you will just see one conva and one fallopian tube. In bicornate, you will see that they are slightly closer together. The intercorneal distance is less than 4 centimeter and the angle is acute. Whereas in case of a bicornuate, they are more farther apart and the intercorneal distance is more than 4 centimeter, angle is obtuse. Yes, you will have all those options. Cryptomenorrhea, yes, Elon, you have rightly mentioned cryptomenorrhea along with imperforate hymen. Cruciate incision. Okay. Finally, coming to Bartholin's cyst. So Bartholin's cyst, the Bartholin's duct actually opens in between the junction of hymen and the labia minora. So the obstruction can lead to Bartholin's cyst, and the infection in this will lead to Bartholin's abscess. If Bartholin's abscess happened, initially we managed it with IND, incision and drainage. If it is recurrent, we go for a management known as marsupialization. So initially the management is I and D. If it is recurrent, we go for marsupialization. The management is by marsupialization. This by marsupialization. Finally, coming to Klinefelter syndrome. So, Klinefelter syndrome, again, so I have given, as we are nearing the end of the class, I don't want you to be too stressed. Everything, all the points are already given here. The Klinefelter syndrome, basically, it's the most common cause of primary testicular failure. Here, the karyotype is they have an extra X chromosome. They are 47XXY. These individuals, they have poor intelligence and there can be some psychosexual abnormality. In contrast to Turner's syndrome, in Turner's, what is happening? There is one X is less. They are 45XO. They have normal intelligence. They have normal intelligence, whereas here they have poor intelligence. And even the gonads are not properly developed here. They have small, firm testes, and there can be cryptorchidism, that is, failure of the descent of the testis. Initially, testis is an abdominal organ, then it descends into the scrotum. There can be problems in the descent of the testis, that is cryptorchidism. So, testis is small, testis is not properly developed, all problems related to testis. So what will happen? The testis is not properly developed, even the sperm production is not proper. The testis is not properly developed, so the testosterone being produced is also low. As testosterone is low, there is no negative feedback as such, right? Due to which the FSH is high in these patients. The question that was given is, there is a tall male who is having infertility, who has gynecomastia, breast development. What is the diagnosis? So these individuals, they are usually very tall. They have long arms, long legs, and they can have some breast development. Even they are at risk of having a breast cancer as well. They are at risk of developing breast cancer as well. How will you diagnose it? It is basically by the karyotype. The karyotype is 47XXY in these individuals. Again, this topic has been repeated twice for the exams as well. A very important topic. So we are nearing the end of the 3-hour discussion which we have planned. So I hope you learned a lot in this session and you recollect a lot in this session as well. Is there any questions? So the comments, they have been, okay, have been very active in the comment section. Actually, that is so good. Even though I was having a lot of throat issues, I felt really motivated to speak despite my throat pain because the comments section has been so active throughout the class. Thank you so much. And if you have any more doubts, queries, if you want to connect with me anytime as well, you can, this is my Insta link as well. You can join. There is a lot of discussion and questions which I post daily as well regarding the previous year questions and all. So we can get connected as well. Telegram link I have not posted here. I have a Telegram group. So it's there along with the Insta page in the links. Yes, definitely PDF will be available. Do not worry. Definitely will be available. So in some places where I think the handwriting was not that clear, I'll just change it and it will be shared. Don't worry. We are nearing the exams. I want you to revise this repeatedly. So definitely I'll share the PDFs with you. You can sleep peacefully with that information. Don't worry. It will be definitely shared. It will be available in the Telegram group. Any other doubts or questions? So thank you so much. So if you have any more doubts, please connect with me. No problem at all, anytime. So we'll call it a day today then. Good night and very best of luck for your exams. Do not worry. You're going to do wonderfully well in the exams. Don't worry. Have faith in yourself and give your best. All right. Now I know there is a lot of tension because the exams are nearing. Do not be in a tension. Everyone is in the same state of mind. Everyone feels that the exam preparation is not completed. There is a lot of stress during this time. Believe me, the topper, everyone has the same feeling. I know that you are very well prepared. Believe in yourself. And it's not possible for anyone to cover 100% of any subject. That's not possible. Do not worry if you left something out or something is not covered. Please don't be in a FOMO and all. You're going to do wonderfully well. All the very best for your exams. My prayers and wishes with you. Good night.